Please, while we await the Nurses anthem, please give us the national anthem while they search for the. Give us the national anthem while they search for the Nurses anthem. Thank you.
We are called to serve humanity, endowed with the art and sense of caring. We are built on integrity and discipline that transcends through every generation. Immaculate and amicable, we are the salt of hope to ailing ones, and the foundation for building a healthy world. Together we shall stand. No seas of grace, no seas of caring, and epitome of humility and service. We especially ordained for this vocation. Yes, I'm proud to be a nurse. From near and far we have gathered with one goal, to uphold the good name of our profession, and for neatness and splendor, you for understanding, I for responsiveness and selfless service, I innovative and initiative, and for nobility, G for gentleness and love. The seas of grace, no seas of caring, and every tone of humility and service. We especially ordained for this vocation.
Yes, I'm proud to be a nurse.
Thank you very much. Please, may we be seated. I think. Hello. Hello. Great Nigeria nurses. I think next year we will not play the anthem. We will sing it by ourselves. Because I realize the tune today has increased because it was visualized. But previously, if the music has been played, majority say N for H for I say, well, when I don't become choir. On a very serious note, next year, by the grace of God, just like I said yesterday, all of us here by the grace of God, and those who could not come today will be here next year. Nobody will be missing among this. Yeah. We are very distinguished ladies and gentlemen, comrades and friends. Thank you for coming for another yet edition of this long week celebration. Indeed, the strength of a people is for them to come together and keep aside differences, develop the spirit of collective interest, develop the spirit of conflict resolution. Let's see ourselves as together and believe in one ideology that will lead us to our strength. Because our employers will be very grateful if we have loggerheads, if we have conflicts, if we are divided. That is the strength of our employers. We should never allow that to happen with us. We should never create any gap so that our employers will take advantage. So thank you. God bless you all. Today again, yesterday we had our opening ceremony with very, very beautiful presentations. In fact, the discussion of yesterday, I said yesterday was very, very enriching. Hello? If you were not enriching yesterday, then I don't think you will ever be enriched anymore. From the keynote speaker, she gave us an insight of the reality. And the other discussants again gave us another reality. And I think because after this, let's compile a communique, build this, and then let it reach the corridors of power, both with the National Assembly. I mean it very seriously. Prepare it, make sure it is televised, take it to the Ministry of Health, take it to National Assembly, to the appropriate quarters, and make sure there should be a recap with the NTA, especially the national station, because this will help, it will give us more strength. So thank you very much. Today we will continue, and our speaker for today's ceremony will be Dr. Biodun Ogungbo, and he will be taking us on brain and spine, understanding the danger and signs of neurological conditions. Please, ladies and gentlemen, let's put our hands together. I would like to advise that please let us be calm. Please just keep aside whatever you're doing. Put your phones down. Anybody who is holding his phone, in fact, if you keep your phone, you'll have a token of 50,000 naira. If you are not holding your phone, 50,000 naira. After the count of 3, 1, 2, Madam, I will still not give you that 50,000. Keep your phone. Thank you. All right, thank you very much. Please let us be attentive so that at least we take something home to our various constituencies. It will help us. Thank you very much. You're welcome, sir, doctor.
It's important I also let you know that the doctor didn't just come alone. He came with his head nurse, who was our one of our beauty pageant panelists, Ugochukwu Joy. Can you just say a wave to us? Thank you very much.
Good morning, everyone. Thank you for the honor of asking me to come over and spend this day with you. It really is an honor, and I'm humbled to be with you this morning. When I saw the letter, I was particularly pleased with this theme. I think this theme is a great theme and well chosen. And so I congratulate everyone on this FCT Nurses Week and Scientific Forum. I'm happy to be here, and I hope together, moving forward, especially with neurological diseases, we can share. And I may be able to, at least from my experiences now in Abuja, share with you some insights into the topic that I have been given, which is to talk about the danger signs of neurological diseases, problems that affect the brain and spine. What are the danger signs? Let's start this way. We have particular problems in Nigeria. We have problems with religion. And sometimes religion colors our decision-making. And that is a problem. We also have serious problem with poverty, which totally, truly influences healthcare behavior, or where people seek to get healthcare. Then, of course, we have so many doctors. Everybody is a doctor. If you take your problem and talk about it in the taxi driver will give you a diagnosis and point you where to go. If you talk at home, you will find family members who will become know-it-all. They will advise. They will tell you where to go. If you talk to your friend, it's a different story. So many people are in the position of making a diagnosis, offering treatment, or pointing people in different directions. It's a big problem. The other problem that I didn't write there is malaria and typhoid. If malaria and typhoid are a family, they will have relocated a long time ago. They are blamed for everything in Nigeria. And that's because we have a problem with making the diagnosis of malaria and typhoid itself. We actually have a problem with making the diagnosis. If all of us here go to a diagnosis center today, we will all be diagnosed with malaria and typhoid. There will be some titer positive in almost 100% of us. Yet we're here today. We haven't been bitten by mosquitoes. We haven't eaten food that is contaminated with fecal matter. So where does this malaria and typhoid diagnosis come from? I'm hoping today, with us talking together and collaborating and just having these few minutes to discuss, at least for neurological diseases, maybe malaria and typhoid will be the 100th diagnosis that we will make. This is very important, that the more you read, the more you learn, the more you see. Suddenly things become a bit clearer. I have chosen just a few symptoms to talk about in highlighting my talk this morning. Just a few symptoms. But I hope those are the key symptoms that affect both the brain and spine. And so long as you, as the nurses, as our future, as the people who many times you're the first person that a patient will want to talk to, if you can appreciate from this presentation these symptoms and the importance of those symptoms, then you will be doing a great help to the patient that's in front of you. The key thing always is to get the diagnosis correct. That actually truly is all we need to do. If we have the right diagnosis, treatment becomes a bit easier. And there are so many times these days when I have to put my hands up and say to the patient and family, I have no idea what's going on. I don't know what's happening here. I don't have a diagnosis. And if I don't have a diagnosis, I don't have a treatment. So we may have to find somebody else, or we may have to find a different test, or another, just get somebody else to look at it again to see whether they can then move us in the right direction. I had a patient recently who was complaining of pain in the right hip, and he had been referred to me because of lumbar spondylosis, pain in the back, radiating down the leg. And I looked at him, we talked about it. He kept saying the pain is here, the pain is here. Not so much down the leg. Yet when you look at his MRI scan of the lumbar spine, he had a lot of problems in the spine that ordinarily need treatment. But his pain is just in the right hip. So we had to stop. What is causing the pain in the right hip? So we sent him for further MRI scan. And lo and behold, he came back with a tumor, big tumor, centered in the right hip. You appreciate where I'm going with this? If we didn't stop, if I said I'm a spine surgeon, somebody has sent me somebody with back pain and leg pain and an MRI scan that shows problem in the spine, then I go off operating on the spine. I've had patients who have come, elderly women especially. Mama can't move her leg. Mama can't move her leg. There's pain in that leg. They've done MRI scan of the spine. There's lumbar spondylosis. So off she comes to the spine surgeon. Mama, move your leg. Can't move the leg. Why can't Mama move the leg? The hip is broken. So she doesn't need me. She needs an orthopedic surgeon. You appreciate this. So getting the diagnosis right is perhaps the most important thing that we need to do. Getting the diagnosis right for the brain, means understanding the brain. I like to say this, though, that when God made us, let's say he gave us 300 billion naira of nerves that makes the brain. There's a lot more than that, but let's just use the number 300 billion. That's all we have for the rest of our lives. Also, the nerves that come out from the brain, there's a specific number of those nerves, what they do, where they go. For as long as we're living, each day we're losing some nerves. The brain is shrinking. You understand? Okay, so out of the 300 billion, every day we're losing some. Diseases like hypertension, diabetes, stroke, or anything that affects the brain or the nerves is further reducing that number. So with stroke, for example, once you lose part of the brain, you've lost a lot of nerves, you've lost the function of that particular part of the brain, and it won't come back. God has, as at today, not given us the capacity to replace the brain. Yeah? We can replace the heart. Kidneys, you can have a new kidney. You can have a new liver. So many different organs that technology and wisdom has allowed us to be able to replace. The brain and nerves are still hidden from us. People have tried using monkey brain or doing transplants. It hasn't been successful. Maybe one day it might be. But as of today, we have only what God has given us. And that's all we have to use. Yeah? Parts of the brain, different parts do different things, which make our life a bit easier. So if somebody comes with problems with personality, behavior, we're thinking that may be the frontal lobe. If they have problems with their speech, temporal lobe. If they have problems with sensation, parietal lobe. If they have problems with their vision, occipital lobe. So different parts of the brain do different things. So when patients present, depending on what they are saying and what we see in examining them, we can start thinking which parts of the brain may be affected, and that helps with making a diagnosis. So the frontal lobe, problems with solving motor function problems, personality, behavior, emotions. Temporal lobe, auditory processing, language, memory. Occipital lobe, visual perception, interpretation. The cerebellum, which is at the back, to do with coordination and balance. So different parts of the brain do different things. One of the most important things in making a diagnosis for us as a neurologist or as a neurosurgeon is the patient. You actually have to understand who the patient is. And I spent some time just getting to know who the patient is. Who is this person in front of me? Male, female, married, single. How old are they? Do they have children? Do they take alcohol? Do they smoke? Do they have hypertension, diabetes, asthma, ulcer? Have they had an operation before? So I get to know who this person is first before we even start talking about symptoms. Because once you know that person, if you know they've had an operation before, then at the back of your mind, when they start talking about the symptoms, you're relating whether that may be related to the previous operation, or it may be related to their gender, or it may be something to do with them having hypertension or diabetes. So many different baseline information is important, even before we start talking about the symptoms. Does that make sense? So when you have a patient come to you, one of the first things to actually understand who is this person and how might who they are relate to the symptoms and signs that you may find on examination. So the patient is very important. This gentleman with me is a son, and we'll talk about him later on. But he sits for long hours, as these erudite senior lawyers can do, reading and writing lots of stuff, written lots of books. So when he came, the fact that he was a lawyer who sits for a long time, who is bent over writing for a long period, actually has a role to play in the symptoms that he then subsequently presented with. One of the most important symptoms for brain issues is headache. We all suffer from headaches. Yeah? And so we may not make a big deal out of headaches, but there are some headaches that when you hear somebody describe the headache, it gives you cause to pause and say, this does not sound like a normal headache. Yeah? The first one is this headache that is sudden. Like somebody just turned on or switched off the light, or there's an explosion in the head. A sudden, severe headache is important. And they have to describe it like that this headache is sudden and severe. If it is sudden and severe, horrible headache, the kind of headache that they've never had before, that is important. That is not the kind of headache you want to go to sleep on and say, I will deal with this tomorrow. That headache often means that there's a blood vessel burst in the brain and that they have had a stroke. So sudden, severe, horrible headache is a very, very important symptom. Headache that is also in the same place all the time, even if it comes and goes, but it keeps returning to exactly the same place. That kind of headache is very important. If somebody comes to me and the headache is moving all over the place, it's here today, on this side tomorrow, at the back, at the top, sometimes, you don't really worry about that. Because a headache that is moving around, might be stress-induced. It might be nothing to truly worry about. But if the headache is in the same place all the time, that there's something in that particular area that's causing the pain, that means you give that headache a bit more significant than a headache that is moving around the head. Does that make sense? So for headache, if it is sudden and severe, very important to take note of it. If it's also in the same place for that person, same place all the time, it is important. It means that there may be something in that particular area that is causing that headache, and it's just in that area, and that's where the focus needs to be. One of the things I say is that when our patients come to us, more often than not, they on their own give us the diagnosis. They tell us exactly where their problems are. Oftentimes, we then step off the path, leave the problems there, and start taking a different direction. If somebody comes like the man I described to you before, and he says, my pain is here, yeah? No matter what else is going on, you must at least evaluate that particular area. So if somebody comes and says, my headache is on this side, you do need to look at that side and be sure, 100%, that you've looked at that side and there's nothing in that area. It's until you can 100% guarantee that you have looked at that side and there's nothing in that area, you will not make the right diagnosis. So oftentimes, that's where we veer off. The patient is talking, I'm on the phone, I have my own issues that I'm worrying about. Before they even finish, I've written malaria and typhoid, go and do this, and then start taking a thermometer and forget about it. That's what happens a lot in many of our hospitals. So long as the patient comes and says, doctor, I have a headache, oh, don't worry, it's malaria and typhoid. Next patient, and that is the kind of scenario that we see playing out in our hospitals a lot of the time. So talking about headache, those are the two key things about headaches that I'd love you to take away. A headache that is sudden, severe, the kind of headache that the patient has not had before. Do not let them go away until it's been evaluated on that day, as soon as possible, to find out why that patient had a headache. Even if it had gone and they're perfectly well, something caused that severe headache, and you must make sure you know what it is. If they come, no matter whether it's been for months or years, but the headache is exactly in the same place, they also need to be properly evaluated. So, I'll change tactics a little bit. Headache baseline, yeah? Headache that now has JARA attached to it. Yeah? By JARA, I mean something else, another different symptom. So somebody comes and says, doctor, I have headache. I've always had this headache. But recently, I've now had cloudy vision. Or there's now a problem with my vision. It now has a headache as baseline, but now has Jara, yeah? They've now put spice on that particular headache. So when they now start talking about a different part of the brain that is affected in function, as we said before, different parts of the brain do different things. So when they start adding Jara to it, that makes it even more important to be properly evaluated. I cannot tell you how many patients I've seen who have been going blind slowly over the years. They've visited optometrists, ophthalmologists, hospitals. They've seen nurses. They've seen doctors until they finally go blind. Or they present with significant blindness and a big tumor. So this one we're looking at is a pituitary tumor. I don't know if it's possible to point this where the arrows are. That's a tumor inside the brain for somebody who has been having some headaches over a long period, who has seen optometrists, who has seen ophthalmologists, who has seen family members, and until they now add a Jara that there's blindness. So when they add something else to the headache, it's even more important to take it serious. Does that make sense? The one other symptom we should talk about is seizures. So, very important. Poorly diagnosed, poorly treated in Nigeria, mostly because of poverty. Mostly because of poverty. We're not making the diagnosis correctly. We're not evaluating patients properly. We're not treating them well at all. There are lots of people who go through life, hidden away because of seizures, not able to achieve their potential. I don't think that there's any solution to this problem because fundamentally, seizures by itself, in a majority of cases, there may be nothing seen on the brain. But there are some times when there's a brain lesion, but they do need to be evaluated by a CT scan or an MRI scan. Now, for the majority of Nigerians, many people, millions of people, cannot afford 50,000 naira, 60,000 naira, 80,000 naira for an MRI or a CT scan. You appreciate this. So seizures, poorly diagnosed, poorly treated in Nigeria. But it's a very important symptom that points specifically to the brain, that there's something happening in the brain of that individual, whatever it may be. But when somebody presents with a seizure, there's something going on in the brain. We may be able to make a diagnosis. 70% we may not see anything on the brain, but there is something on the brain. If an adult, somebody as old as I am, starts having a seizure, that is critically important. If they were not born that way, they've grown to be as big as you and I are, and then starts having a seizure, you have to assume that they have a brain tumor until proven otherwise. There's something going on in the brain. Whether they have a headache or not, if somebody presents with a seizure, the problem is in the brain until proven otherwise. And if it's an adult, they need to be evaluated. This person, the scan is showing a tumor in the right frontal lobe. So headaches. Then the headache is now complicated by seizures. There's also change in personality. I actually met a woman once before who her husband brought her to the hospital because she had stopped sweeping the house. She was somebody who was quite meticulous with cleanliness. But over some time, her husband noticed that she had now ignored all those chores that she was particular about. So this change in behavior was what prompted the husband that this is not my wife, that this woman has changed, there's something going on with her. And lo and behold, when we did the brain scan, she had a huge tumor in the right frontal lobe, which has changed her personality completely. Yeah, so different parts of the brain do different things. So their presentation might reflect the particular area of brain affected. Does that make sense? So if there's a change in behavior, change in personality, then we have to start thinking that area of the brain affected, maybe the one that controls personality, behavior, or who this person is, their emotional reaction to things. So that may prompt, investigation and a proper diagnosis. So if they have a headache, they have seizures, they have a change in personality, any of those symptoms are added jara on top of what they're complaining about. It prompts further investigation and a proper diagnosis. Nausea and vomiting is also a very important symptom. Yeah? So if somebody has headache, for example, and they have on top of that nausea and vomiting, it also makes it very important to take it quite serious. Nausea and vomiting actually means, for us, raised intracranial pressure. It means that something has increased the volume of the brain in the tight skull. And because of that, it affects the vomiting center. And so it leads to them, having nausea and vomiting. So patients with nausea and vomiting who are also complaining of other issues related to the brain, they should be taken quite serious. So I say add jara. For children, they may not complain of a headache. They may just know that they're unwell, that there's just something wrong with this little boy or little girl. Yeah? If they now have difficulty in walking, especially children, they have nausea and vomiting, difficulty in walking, very important. Those children may have a brain tumor, like this one showed here in the middle. That white thing in the middle of the brain is a massive brain tumor in the cerebellum that makes them particularly unwell, but it now then starts causing difficulty in walking. And that is very important. You wonder why these brain tumors become so big. But it's because a lot of the symptoms initially are subtle. Yeah? The child may vomit just once, or maybe it was something he ate yesterday. It's when it becomes more frequent. But more particularly, when they start having difficulty in maintaining their balance. And we have a lot of children who come down with tumors in the posterior fossa. And that's oftentimes, it's a late diagnosis. The tumor is so big that it causes us problems in their management. Yeah? So, another brain tumor here. Somebody who was complaining of headaches on the left side, but it wasn't until the right side became paralyzed that the diagnosis then came to light. So left side of the brain controls the right side controls the left side. So this is somebody who's been having headaches, it's been ignored, but when the arm and leg start getting weaker, on the opposite side was when they said, there's something funny going on here, and that prompted, referral investigation with an MRI scan. We showed that tumor that you see on the right side, on the left side of the brain. Does that make sense? So just to recap for the brain, those symptoms that I've mentioned are the key symptoms that are important, or perhaps for me, most important. Headaches, seizures, nausea, vomiting, difficulty in walking, very important. Those symptoms need to be evaluated as soon as possible. So if you know who your patient is, you can start relating their symptoms to who they are particularly. But when they start having additional symptoms, somebody who's been complaining of headache starts having seizures. Somebody who's been complaining of headache now saying that they're going blind, or they can't see properly, they're getting blurring of vision, or the pain is now behind the eye. Those are important. Somebody with headache having nausea and vomiting, very important. Somebody with headache who is now having difficulty in walking, very important. We may already have missed the boat, but at least from the point that you may be in contact with them, you should advise them. People with symptoms related to the head, they need to be evaluated. We need to see the brain itself. We need a CT scan or we need an MRI scan. It's when those are normal and we can't see anything, then we step back, take another look, start again with the history. What else is going on? What are the other parts of, what other clues will help us in making a diagnosis. And so you find that with seizures, for example, if we already looked at the brain, we don't see anything on the brain, we can ask for an EEG. Let's see whether looking at the electrical activities in the brain might help point us in the direction that even though we don't see any abnormality on the brain itself, physically looking at it with CT or MRI scan, there's some electrical abnormality going on anyway, which will help us in making a diagnosis. Does that make sense? Are you all going to become neurosurgeons now, yeah? But it's easy, isn't it? So long as you just step back, listen to the patient, just hear what they're saying, the diagnosis might become clear, or at least give you a direction to point them to. Yeah? Even if all you say is, we need to look at the brain, it's a big step forward. So long as we do not allow religion and poverty, to get in the way of making the right diagnosis. The spine is a bit different. Yeah, so we're going to talk about the spine. Same thing, when the patients come, they tell us where their problems are. Doctor, my pain is in the neck, and that pain in my neck goes to the right arm. Doctor, my pain is in the back. Some might say it's in the lower back, some might say waist, but they tell you exactly where their pain is. And they tell you whether it's going down one leg or both legs, whether it's going inside into the groin, to the knee, or down to the ankle. They tell us, yeah? Anatomically, the different nerves that come off from the brain, they go to different parts of the body. So starting from the neck, C4, C5, C6, all those nerves, they have specific areas they go to. They go to a particular muscle, or they go to a particular area of skin. And the thing with the nerves, for example, in the neck is they go to the upper arm. Yeah? When the patients describe their pain, if they say, for example, there's neck pain, the pain goes to my shoulder. It doesn't go below the shoulder. I'm thinking in my head, shoulder is C5. So if I was going to investigate them, I'm looking for a problem affecting the C5 nerve root. Yeah? If they say it goes to my thumb or to that particular area, I'm thinking C6. This finger, C7. The little finger, C8. Does that make sense? So as they're talking and describing their symptoms, I'm looking at them internally and thinking which nerves are affected in what, same as the brain. When they're talking about their particular problems, I'm thinking which part of the brain is affected. So for spine as well, which nerve is affected? Yeah? So lower back. Doctor, the pain goes into my groin. I'm thinking L1, L2. It goes to the anterior thigh, L3. Inner part of the leg, L4. Outer part, L5. Under the sole of the foot, S1. Does that make sense? So I'm following them anatomically like that and thinking which nerve is affected, because when I look at the MRI scan, the problem should be in the area where their pain is. Does that make sense? Otherwise, we don't have a diagnosis. The symptoms, the signs, the MRI scan, or any investigation, they must all speak the same language. Because it's only then that you make the right diagnosis and you offer treatment for that diagnosis, you solve the problem that they present with. Does that make sense? Okay. So the patient is important. The symptoms are important. The signs we elicit to confirm. So if they say that my right leg is weaker than my left leg, I'm examining them to confirm that indeed, when I examine them, the right leg is weaker than the left one. If they say I have numbness under the sole of my foot, I'm checking that. Can you feel this one? Can you feel that one? I'm comparing right and left to confirm that, yes, indeed, they do have what they say they have. There's numbness on the right side that is not present on the left side. Does that make sense? So the clinical examination that comes after listening to the patient is just to confirm or reaffirm what the patient has said. By the time they finish talking about their symptoms, we should at least have an idea where the problem is. Knowing who the patient is will give you an idea what kind of problem they're presenting with. So let's talk about that patient, the elderly gentleman that I was with earlier on, who is a lawyer that sits writing and reading for hours every day. And he comes in complaining of neck pain, right hand pain, weakness of the right hand. Yeah? So, where is his problem? His problem is where exactly he said it was. Where is it? It's in the neck. Yeah? And it will be related to whatever nerve where his pain is going to. So as he's talking and saying, the pain is in my right shoulder, and he can't raise his hand up. So he can raise the left hand up quite easily, no problem, but he can't raise the right hand up because the pain is in the right shoulder. So I'm thinking C5. And indeed, when we did an MRI scan on him, he had a big disc bulging in his neck because of the way he's been bending his neck over the years with pressure on the C5 nerve root. And once that was operated on, his weakness improved, the pain is gone, and that was, I think, about the picture was about 10 years after his surgery, completely back to normal. Let me go back again. We only have 300 billion, say, of nerves in the brain, and we only have the nerves in the spine that go to different parts. Once you lose it, it's gone. We cannot replace it. So neurological symptoms and signs are quite important. When they start talking, and they start talking about weakness, they start talking about numbness, they start talking about difficulty in walking, they start talking about problems with passing urine or passing stool. Very important, because once those nerves are damaged, we can't get them back. So the earlier we intervene to preserve the integrity of the nerves, the better for the patient. Does that make sense? All right. So, pain. One of the symptoms for neurological diseases affecting the spine, very important. If the pain is persistent, it's in the same area, it's very important. There's something there causing that particular type of pain. Let me show you some people. The picture on the left showing the elderly gentleman with the walking frame. Now, when we first saw him, his pain was mostly in the lower back, and he came walking bent double like that, and he needs support. Elderly chap, can't straighten up, yeah? That's his kind of pain, yeah? The chap at the top with his wife in the middle, same thing, back pain, yeah? But also bilateral leg pain. So his pain is not only in the back, but is radiating down both legs. Yeah? The young woman in green, she's an event planner. One day, sudden, horrible, severe pain. She also came into hospital walking bent double, but the pain she describes is only going down into one leg. Yeah? So one leg, only one leg affected with her pain, but horrible pain that she's also walking like an old woman, and can't straighten up. The woman far right, she came with neck pain. Her neck pain is not like that of my son, the senior advocate of Nigeria. No, not like that one. Her pain goes to both shoulders, down both hands. The pain also shoots down the back of the neck, and she has difficulty in walking. So she has neck pain, bilateral arm pain associated with difficulty in walking. You appreciate that the pain for the 4 patients are totally, completely different, and they come up with different diagnoses. Yeah? So, when we did X-rays and MRI scan on one of those patients, the MRI scan showed a disc bulging affecting one single nerve, the L5 nerve root. So this MRI scan is showing a disc at the area where the arrow is that is affecting one single leg, right leg, L5 nerve root. Which of my patients has that particular problem? Anyone? Sorry? Which one? Which one has the diagnosis, the MRI scan fits the diagnosis, this one. Yes, dear? Sorry? The man with the walking frame? No. His pain is just back pain and he's walking bent double. Sorry? Which lady? The one in green. The one in green, the event planner. She has back pain, horrible back pain, shooting down the right leg. Only one leg. So when we did the MRI scan showed a disc bulging. That disc, where the arrow is, pressing on the nerve itself, only one single nerve. Does that make sense? So even in the evaluation, in the clinical history taking, and in the examination, I could say, oh, this person likely has disc bulging because it happened quickly, acutely. Shooting down pain, shooting down just one leg, going into just the L5 dermatome. And when you examine that, there's weakness, of the L5 nerve root. So these symptoms, by the end of her talking about the symptoms, or any of them talking about the symptoms, I'm already thinking this is likely the pathology. And so when we do investigations, it should confirm what their symptoms are. Yeah? Because that's when we know that if we operate on them or we give them treatment for that particular problem, we will have reversed the issue and therefore be able to eliminate their symptoms. Weakness of an arm or leg is important. Yeah? When they say that their hand or leg is weaker than the other one, we must take it as very important. Because once you lose it, we can't get it back. This is the key thing about it, and I'd love that emphasis to run through all of this. With brain and spine issues, we only have the nerves that God has given us. When they've lost it, they've lost it. Numbness itself, when people talk about numbness, it's a particularly difficult diagnosis to treat. We don't have any treatment for numbness. We have physiotherapists for weakness. They can help. So long as the nerve is now working, they can help to get the muscle back. Does that make sense? So we protect the nerve. Once we protect the nerve, the muscle that is weak, physiotherapists can help to get the muscle bulk back, to get the function back. Numbness, there's no treatment for numbness. So when they start complaining about numbness, it's an urgent kind of issue, because if it becomes permanent, it won't come back. And we don't have any drugs for numbness. So, this just shows, parts of the spine with one bone not sitting properly on another one. And oftentimes, those are the kind of people who bend forward because there's imbalance in the spine. They may not talk about pain going anywhere else, but pain is in the back. And the pain often, if they're lying down, it's okay. But as soon as they stand up and the spine is not balanced, they have to now find different ways. So you might find some people are walking bent to one side, and just to help to rebalance the spine, or they're walking bent forward because that's a position that eases off the pain. So different conditions like that will make the patient present in different ways, that once they start telling us their story, we can understand that there's a serious problem, going on. So if there's somebody walking bent like that they can't stand straight, likely the spine is unstable. One bone has shifted on top of another one, and the X-rays, the MRI scan, or CT scans will show that particular problem. So on the right is a CT scan showing one bone not sitting well on the other one, and then the MRI scan shows that the canal in that area is also closed up because of that shift and pressure on the spinal canal in that area. When people talk about difficulty passing urine, difficulty passing stool, in association with pain, back pain, leg pain, difficulty passing urine, difficulty passing stool, very, very important. People also have problems with sexual function, very, very important. This particular symptom, we take it quite serious, because in some situations, especially when it's acute, when it happens suddenly, it may be because of something called caudal equina compression, where all the nerves supplying the anus, supplying the private parts, are under pressure. If that is happening to somebody, if they're complaining of back pain, leg pain, problems with passing urine, problems with passing stool, it's an emergency. We need to rule out that they don't have this particular problem called caudal equina syndrome. Because if they have it, we must fix it as soon as possible. Otherwise, this problem passing urine, problem passing stool becomes permanent. So you find some young people especially who have acute disc prolapses with problems passing urine and problem passing stool. If we don't operate in time, passing urine becomes constant. They can't hold the urine, it just keeps coming out. And they become constipated because they can't go to pass stool unless somebody is doing an enema or some other kind of therapy. So difficulty passing urine, difficulty passing stool is one other very important symptom that when patients talk about that, we take them serious. That's my talk. Thank you so very much.
Please, we can do more than that, please. Let's put our hands together. This is a very, very wonderful paper. Let's clap again, ladies and gentlemen. By Dr. Biodun Ogunbo. Indeed, sir, you have taken us around the strength of our own profession, despite the fact I'm not a nurse, but hence I'm associated with them. I'm a nurse for it. So now, you have taken us around with what I read and with what I had here had added value to my strength of knowledge. And after all, I think we should give him more applause, ladies and gentlemen. May we please we will take maybe one or two questions, if there is. Because do you know why sometimes you ask questions? It's because maybe why you add more food, maybe you didn't eat well. If you eat well, you won't add more. Am I okay? So now, if you listen very well, and if the message is well sent, the questions will be minimal. But I appreciate, Doctor, you've done justice to this very wonderful paper. We've benefited from the fountain of your knowledge. Like me, at least I can be a self-nurse. You said anywhere there are doctors, but so this is a victim now. So if I go home now, if I hear you are feeling headache, I want to say, okay, let me go. Let them check your brain. Have you checked your brain? If I don't have the material to check your brain, I'll go and buy a screwdriver. So please, I think we will take a few questions, please, because we want everyone to benefit from this very scientific workshop.
Thank you very much, sir. My concern is on the symptoms you mentioned for numbness and then difficulty in urination, stooling, and also sexual function. I noticed some of our patients that have diabetes comes with the numbness stuff and also with sexual dysfunction. How can we relate that, sir?
Hence, it's not right. Let him answer immediately.
I think that what you said is very important in us differentiating whether this is due to diabetes or any other, or peripheral neuropathy, for example, or a problem related to the spine. And that's why, I started by saying, you need to understand who your patient is. And they will tell us, I'm diabetic. I've been diabetic for so long. And so in the calculation, in making a diagnosis, you already put that into the equation. And especially if they come not complaining of back pain, for example, I don't have any reason to go and examine their back looking for the cause of the numbness, especially if somebody says, I'm diabetic. I'll go down the route of diabetes first and ensure that they have perfect control or good control. I don't go looking for trouble. Yeah? But if somebody comes complaining of back pain, leg pain, and they say, I'm a diabetic, then you put the diabetes into that equation. So although you're still evaluating them, for the spine to see whether that's where the problem is. If the spine is clear, you come back to the diabetes. But if there's a problem in the spine, you don't blame the diabetes, you control the diabetes, and then still look at whether the spine is where the key pathology is, and then you treat that. And then you see exactly, whether looking at both sides, treating the diabetes and treating the spine issue actually then solves the problem. But my emphasis really is on numbness as a symptom that we don't have treatment for. And also, difficulty in passing urine, difficulty in passing stool may be symptoms that allow or enable us to ginger up to do things quicker. Because if they lose that function, they may not get those things back. And that's it's devastating. It actually destroys people's self-confidence. They can't go out if they're going out wearing Pampers or they have a urinary. It destroys lives. So the sooner those are properly evaluated and managed properly, the better for the patient.
Okay. Good morning, sir. Thanks so much for the presentation. I have two questions about the headache. I've happened to experience some kind of headache that is not described. So I just want to understand what might be happening. There are some kind of headaches that come with malaria parasite infection. Most of the times it comes when there's that infection, and it comes as migraine. Once it's treated, it goes, the headache disappears on its own. But it's always coming back once there's another episode of raised parasite in the blood. That's one. Then two, there's a kind of headache that comes as if it's a bang, and the direction comes as if it's coming through the ear. Then when I turn to the other side, I get a little relief, and the pain is modulating. Like it comes a little and it starts increasing with time. So those are the two kind of headache that was not described. Then the other question is, for people who love reading, I want to seek your advice. What's the best position to sit while reading? Because for young people like myself now, who love knowledge kind of, and you read more in the night, if the lamp is facing down, the book is down, you will have to bend your neck. So what do you advise, sir?
Thank you so much. Can I take that second question first? We now are seeing patients or people with neck pain because of the position they adopt in looking at mobile phones. And a lot of us are guilty of that as well. And you find that because we're now attached to our mobile phones, we keep our necks bent down, in that way. And that is affecting a lot of people complaining of neck pain. So I do talk to my patients and tell them, to watch how they hold the phone, and especially advise them not to read in bed or watch television in bed, because those positions keep your neck kinked or flexed unnatural. And so that can lead to muscle spasms in the first place, and then sometimes it can progress onto cervical spondylosis, and they have problems that is avoidable. So we are seeing a lot of patients, and especially young people, with neck pain because of their mobile phone addiction or mobile phone use. But a lot of us are guilty of, that now. The kind of headaches you describe, it depends on, who you are, what, any particular medical history to enable us to think whether this headache is important, to focus on or not. One of the things I wanted to stress as well was about malaria. A lot of patients actually come and say, "Doctor, is that that same malaria that I always have? It's come back again." And it leads some of us down the wrong path that you say, okay, fine, let's do the same treatment that we did the last time. But nobody suffers from malaria every month. Seriously. But yet you have people come in and say, it's that same malaria. And so they've treated malaria, they've treated poorly treated malaria, they've treated resistant malaria, they've treated resistant malaria. They've been treating the same malaria. When it becomes like that, the nurse, the doctor, we must pause and say, let's actually evaluate this patient properly and find out what is the underlying problem. and not keep going down that rabbit hole of treating malaria all the time. Thank you so very much.
Okay, last one. Thank you, Dr. Biodun. Honestly, I have learned a lot from that presentation. Now, from the opening, you raised this fundamental societal impression about the issue of poverty, the issue of religion, and all this. Now, the poverty aspect, if you observe over the years, generally neurosurgical conditions are expensive to manage in terms of MRI, 60K, this one, you know. And here we are, you see a man with a 10 million naira car, or he has a lot of assets. We change our car tires, change our engine oil for the cars every month. But to agree and pay 60, 100K, he or she will tell you it's too expensive. So if you look at it in terms of poverty of money, you cannot say that person doesn't have the money. But that concern to say, let's treat ourselves, let's service ourselves as we are servicing some of these vehicles, is missing. So generally, what do you advise? To us, especially as nurses, because as a nurse, the nurse will tell you, I don't know when last I took my blood pressure. And once there is headache, you say because of the night duty. So we've already concluded that it's the night duty that is bringing the headache. It's stress. So what do you advise generally? Peculiar to us.
Thank you so much. I think I'm hoping that you won't blame night duty anymore for headaches, and you'll get it checked out. But you're right, sir. We have particular issues. Before diagnosis centers became so prevalent and everywhere, and easier access to people going in and out and say, can I get a medical check? And I do some blood tests and do this to see if there's anything wrong with me. We had an issue. But I think a lot more people now go to diagnosis centers by themselves and say, oh, I do a medical check every year. That has become a bit more common. I have my own particular problems with that. I think it is like, you just throw a net and say, let's see what we catch. And then somebody has to interpret what you catch to see whether this is important for you as a person or not. I don't like that. I'd love that everyone has a general practitioner or some person that you're attached to who knows who you are, who can then say, for this particular person in front of me, these are the tests that are important to do regularly to ensure that you're in good health, knowing who you are and what your history is. I think targeted medical checkups like that bring more fruit or are more fruitful than just going to say, I do a medical every year. Because you may have missed something that you should have done, or you do something that you didn't have to do, or you have results that, now you have to find somebody to start at the beginning with knowing who you are, and then looking at the results to see whether it actually makes sense for you as a person or not. Does this make sense? So although, yes, we have more people going to do medical checkups, it's still best to have somebody who knows that person order the test rather than people just walking into diagnosis centers and then they come back, I have malaria and typhoid or whatever else. Thank you. Thank you, sir.
Thank you very much, Doctor. Please, let's put our hands together to celebrate him once again. Dr. Biodun Ogungbo is a neurosurgeon and Chief Executive Officer, Brain and Spine Consortium, Abuja. Is he going right away? Sorry, I wanted to ask one question. Sir? I wanted to ask one question. I wanted to help you answer one question. The question this man asked about neck bending, did you ask him what was his behavior in the exams hall? Okay, thank you. That's the...
Thank you very much, Dr. Bjorgun. He's a neurosurgeon, and he has given us just a little from his world of experience. And I want to believe that we have benefited from his presentation this morning. Thank you very much, sir. And they are here to also offer some little services for us. The information with the team he came with, they just passed information to me that for the first two nurses who perhaps need their services or any of our relation, you can visit them in their office at Wusetu. They're at Brain and Spine. Please, can you please, the Brain and Spine Consortium. Please project the presentation. Brain and Spine Consortium. That's the name of their Brain and Spine Surgery Consortium. They are at 8B Buchan Christian off Amino Crescent after Barnex Plaza. Barnex is a popular place. So it's after Barnex Plaza in Wusetu. So those who need the first two nurses or any of your relation that need their services, the consultation and registration will be free. The first two. Get that clear. The first two. So if you need that, then after that, as long as you need their services, their registration is 10,000 naira and their consultation is 40,000 naira. So for the purpose of this program, they are giving a discount to that first two nurses. So you mention when you get there, mention my name, make reference to this program you attended to confirm that truly you are near. See, I was telling you earlier in the morning, for those of us who came late, there was a QR code here to be scanned. That is the attendance. You know, we didn't pass any paper for attendance. So if you are here, you register for this program, and you have not done that, make sure you do it before the end of today, because that is our attendance. And it's on that basis that you also be giving certificates. So it's as serious as that. Everyone here should do it, as long as you are a registered member, a participant for this program. It's very important. So for further inquiry, there are numbers to call. They drop their card. If you are interested, you can come and pick your card. It's just that the cards, they have limited copies. And they have some of their staff. They are also around there. Can you just wave at us from Brain and Spine? Yes. You have them there. They came. Thank you very much.
Keep one for me, the card.
Please, the Communicate Drafting Committee. We have Comrade Paul Joseph, FCT Financial Secretary, as the chairman. Communicate Drafting Committee, please take note. It's very, very important. Comrade Paul Joseph, FCT Financial Secretary, as chairman. Then Comrade Nannm Philemon as the secretary. Then Nurse Uche Oyeuchi as member. Chairman Maitama Unit member. Nurse Rebecca Benson member. Then Area Council Unit Chairman member. And also the Secretary National Hospital as member. Please and please endeavor to put your heads together and bring up a very, very intimidating communique, because that will be the strength of this very union. Thank you very much. The next presenter, distinguished ladies and gentlemen, is from a very, very renowned public servant who had served this very country and engraved his name in gold. Indeed, the health sector will never forget his services, and then the trade union movement also will constantly acknowledge his strength and raise of our own struggles. We see him as a role model, clearly with correct documents. Please, can we put our hands together while we invite the next paper presenter with the topic, Nannm Exit from Johesu, Implication and Strategic Tax Ahead to Achieve Investment in Nursing. And this will be presented by the former National Auditor NAMS, Nurse Haruna Mandas. He is presently the MD and Chief Executive Officer at Hatch Global Resource Limited, Bauchi. Please, let's put our hands together for him, ladies and gentlemen.
Great Nigerian nurses, articulate Nigerian nurses, intelligent Nigerian nurses, former Joheso Nigerian nurses. Good morning, the state chairman, the secretary, other SAC members, esteemed SAC members, my professional colleagues. Good morning. I say good morning. Please tell your neighbor, relax. Just relax. You are relaxing, right? Now, I know as Nigerian nurses and midwives, we've been talking Nannm, Johesu, Nannm, Johesu, isn't it? And the issue of should we or should we not exit Nannm, Johesu, today we want to look at it. Nannm exit from Johesu, implication and strategic tasks ahead to achieve investment in nursing. Now, we want to look at this presentation under the following headlines. We'll make an introduction. We take some few definitions. We look at the background of the topic. We look at the emergence of Nannm as a professional association. We look at Nannm area of jurisdiction. We look at implication of Nannm exit from Johesu, strategic tasks ahead to achieve investment in nursing. We look at a small subtopic, standing alone, and we conclude. Now, in 2008, the leadership of the 5 unions in the health sector, that is Nannm, Medical and Health Workers Union, NWAP, NASU, and Southri, came together. And why did they come together? Because that time, the Nannm A fought for a salary structure. You know, before then, everybody was on the same salary structure. Until 2007, 2008, they fought for a salary structure and redesigned it to be medical salary structure and rearrange it in such a way that this issue of level 10, level 12 was missing, only comments 1 to 7. Comments 1, comments 2, comments 3, comments 4, comments 5, and comments 7. Comments 7 was the highest, that is GL 17 for a chief consultant. It was tagged comments 7. So to an administrator, when you hear comments 7, the first thing that is registered in the brain, I don't know which part it will be registered. If you want to know the part, ask Dr. Biedu. As if it is GL7. So it will look small. Are we together? And those were strategies. And that took place and the other professionals within the health sector, nothing was done to them. And it seems that time it was going to be difficult to fight alone. So these 5 unions now came together. The purpose of this noble idea was to unite and have a formidable body that will fight for the interests of their members. And that was what happened. Now, the product of that unity of the 5 unions was the salary structure that came in called what? CONHES, Consolidated Health Salary Structure. A product of what? That coming together. And equally, when they came together, they now found out what name do we give ourselves? Because each union has her own name. They say, okay, since we are joining, let's just put it that Joint Health Sector Union. Let's call it that way. And by law, Johesu is not a trade union. So the only thing is to ensure that the logo of each union is in so that it is legalized. And the labor law and the Trade Union Act also allow for conglomeration of unions. So you have your union, I have my union, we can join together and fight for something. It's allowed by law. But my symbol, my logo must be there. You know, many of us don't know that this logo is critical. Today, FCT can decide to produce something, maybe a book or a wrapper or something with Nannm logo, and members are buying. And one market woman at UTC can decide to use that logo and produce. She will be arrested and prosecuted because she has no locus standi to use our logo. Are we together? So that is why these unions have to release their logo. So those of you who have been seeing communication from Johesu, you see the logos there. Without those logos, I cannot be part of it if my logo is not there. This one cannot be part of it. So that was how those unions came together and obtained CONHES. Now, ordinarily, it was expected that after the objective of achieving CONHES, since that was the purpose, every union was supposed to go back or resume their individual mandate as approved by the Office of the Registrar of Trade Union. But this was not done for reasons best known to the unions. Altogether, it wasn't done for reasons best known to the individual unions. Probably they feel, this coming together is sweet though, why don't we maintain it? Are we together? Now, however, Nannm, on 27th April 2023, in an official statement, announced their withdrawal from Johesu. Now, that was just the background of what happens. 2008, we came together, 5 unions, get for ourselves a name, Joint Health Sector Union, and then fight for a common cause, which was salary structure that will benefit all the 5. And that salary structure was achieved. Ordinarily, they were supposed to retire back to their mandate. That could not happen. And then until April 27th, 2023, Nannm officially came up with a statement that we are pulled out. Now let's look at some definitions. Who is a nurse? A nurse is a person who has completed a program of basic generalized nursing education and is authorized by the appropriate regulatory authority to practice nursing in his or her country. That is by ICN. While WHO look at nursing as encompassing autonomous and collaborative care of individuals of all ages, families, groups, and communities, sick or well, and in all settings. It includes the promotion of health, the prevention of illness, and the care of ill, disabled, and dying people. That is the definition of nursing by World Health Organization. Who is a midwife? Do we have midwives among us here? Yes. Who is a midwife? A midwife is a person who has successfully completed a midwifery education program that is based on the ICM Essential Competencies, that is International Confederation for the Midwife, that's the meaning of ICM. Essential Competencies for Basic Midwifery Practice, and the framework for the ICM Global Standards for Midwifery Education, and is recognized in the country where it is located, who has acquired the required qualifications to be registered and or legally licensed to practice midwifery and use the title midwife, and who demonstrate competency in the practice of midwifery. That is according to ICM 2023. Now, there's another definition of a midwife which I like very well. A midwife literally means wise woman. So, do we have midwives here? Yes. Can you raise up your hand? You are what? Wise woman. You like that one? Wise woman. Midwife is what? Wise woman. So tell your neighbor, are you a wise woman? Or an independent practitioner, specialist in birth and women's medicine. According to Wikipedia 2023. While midwifery, according to World Health Organization, is the skilled, knowledgeable, and compassionate care for childbearing women, newborn infants, and families across the continuum from pre-pregnancy, pregnancy, birth, postpartum, and the early weeks of life. That is midwifery, isn't it? And here in Nigeria, some people want to look down on midwife, not knowing that midwifery is too broad to be kicked aside. I'm just telling you. I like midwifery. It's very, very good. It's so in-depth. Now, what is Nannm? Nannm, this one, anybody can still tell me that. Nannm, definition, yes.
National Association. Nannm means National Association of Nigerian Nurses and Midwives.
National Association of
Nigerian Nurses.
Comrade Deborah, have you heard the definition? National Association of
Midwives.
Tell us.
National Association of Nigerian Nurses and Midwives.
You see, eh? Nigerian nurses. Nigeria nurses. Eh? Nigerian. Nigeria. Now, what's the difference between Nigerian nurses and Nigerian nurses? Nigerian nurses, National Association of Nigeria Nurses and Midwives, and National Association of Nigerian Nurses and Midwives. What's the difference? No, somebody should help me. What is the difference? Oh, Nigeria?
It's a person. Okay. Sorry, when you said Nigerian, you mean you are being specific to an individual. but the country Nigeria is Nigeria. And to me, when you are making a sentence, the and should come towards the end of the sentence. Like saying National Association of Nigeria now. National Association of Nigeria Nurses and Midwives.
Please, who will help me? Yes? You tried?
Okay, I think the difference is just one connotes professionals in the space, while the other one points to citizens in that space. Nigerian citizens of Nigeria who are nurses. Nigeria, nurses in Nigeria.
I think it's a good one. It's clearer. Eh? You tried, though. You tried. But what he said is true. So I've seen a lot of products sometimes. People will write Nigerian nurses. It's Nigeria. Because the association is for all nurses and midwives in Nigeria. Whether you are a Nigerian or a Nigerian or a Canadian, is inconsequential. What matters is you are in Nigeria. Is that okay? So let's be conscious of that. Especially if they form small subcommittee and they ask you to print something, you are giving the printer. Be conscious of what he has printed. If not, they will go and add N. Because they don't know. It is you who knows the context of what you want. They may not know. Is that okay? Now, Johesu, Joint Health Sector Union. That one we know, we've had it, Johesu. Joint Health Sector Union. Implication, something that is implied or involved as a natural consequence of something else. Just that natural consequence of something else. That is the implication of that thing. What of investment? Investment. Yes, commitment of something to achieve something. You know, commitment of resources to achieve better benefits. I want us to take note of this definition because we'll use it later. Commitment of what? Resources. Resources. You are going to commit resources so that you achieve what? Later benefit. Which means the benefit may not be immediate. It will be later. Is that okay? Now, let's look at the background. Recent happenings in the Joint Health Sector Union led many nurses and midwives in Nigeria to call for withdrawal of Nannm from this marriage of necessity. Now, there was nothing like Johesu until the government decided to openly and or consciously hand over. I put that hand over in quote because it's not something that's supposed to be the health sector to one of the stakeholders in the health sector, specifically the members of the Nigerian medical profession. So government either consciously or unconsciously handed over the sector to one profession through the activities by government. And if you observe, there were a lot of issues. When you go on strike, the Minister of Health, the Senate Committee Chairman on Health, the Minister of Labor, the whatever, were all members of the same profession. And so there were blockade, left, right, and center. which was now perceived as government has handed over the sector to one profession. The government treat one out of many like a king among slaves. I remember, apart from commerce, when commerce was achieved, commerce and commerce, the basic salary was the same. And in 2014, a circular just came out. They say the heading was rectification of anomaly. Are we together? That for commerce and commerce to be the same, it was an anomaly. Therefore, there should be rectification. And that was when commerce was jacked up and commerce remained where it is. And that now, since the main purpose was to fight for commerce, because commerce was created, do that for other workers, it was not done. And instead of doing that, another rectification came, because they didn't want to call it a new salary structure. They say it was a rectification of anomaly, because there was supposed to be a ratio gap that was distorted. Are we together? Yes. So because of that, members of Jehesu, what do they do now? They formed Jehesu. They started fighting that collective battle to press home that demand. Though out of this period of collective struggle by Jehesu, there used to be some mutual suspicion, mistrust. And why was it? When you call for strike, especially those of us from the federal health sector, when you call for strike, the government will bring no work, no pay, and nurses and midwives will almost 100% obey the strike. Some people will come and lock themselves in their lab, and they will be signing register. The people from the pharmacy will say, no, I came to give them key to essential drug. My sister and brother, the nurse, was at home because they are obeying our leaders. They say, we should not come near. So when no work, no pay was done, before you realize, it was only nurses that were affected. Those of you from federal, you know the AM. When I say AM, you understand. What is AM? April and May. In our hospital, April and May was almost 95% only nurses. Honestly, I felt bad. I felt very, very bad. So nurses were complying, and instead for us to stay on the mandate, what was the mandate? Salary structure. Other things begin to come. Lab internship for lab, internship for that, internship for this. Other demands by other professionals within the health sector became on the banner. And the nurses issue was never on the banner. It really worries us. I remember when we were talking about our scheme of service. If you are talking about scheme for pharmacists, scheme for this, you remember at a point even there were consultant pharmacists that was approved. Then why was it not approved? Consultant pharmacist, consultant lab scientist, consultant nurse. If we are fighting the same cause. Are you getting me? So this thing became an issue. We are fighting the same cause. Put our issue. Let's give gamut of all our issues. No. We take them one at a time. I have participated in Johesu meetings severally. I have represented Nannm severally. I say, no, you know go bill. You can't have a union. In fact, sorry to say, I'm not demeaning any union. But I know some unions within the 5 that don't have any state secretariat. The secretary is the secretariat. I'm telling you, I had to challenge one like that when we met for a meeting. I say, when we are talking about our members, where are your members? Where are they? You write circular, you are the members, you are the secretary, you are everything. We have structure to follow. You don't come overnight and just send a circular today and say nurses tomorrow should just start strike. It's not possible. The nature of our work is unique. You can lock all the pharmacy shops in all the hospitals in Abuja. People will still have access to drugs. I don't know whether you understand. They will still have access to drugs. You can decide to lock all the government medical lab. They will still have access to investigations. But where will people have access to nursing services? None. So we are uniquely unique, and so you cannot coerce us to all this mongering for strike. Of course, using our number, using our contact, using our influence. Honestly, I've made a lot of presentations in Nannm meetings that, to me, if you are my wife, and your strategy to make me give you money always to say is, you have headache, I'll give you money. Now, when you now discover that you tell me you have headache, I did as if I didn't hear. Tomorrow you say, okay, I have headache, or severe one. I did as if I didn't hear. Are you not supposed to change tactics? Can't you change tactics? When we give notice of strike before, government will be shivering. Hey, health workers, it's a problem. What do we do? Commissioner will call this one will call this, governor will call this, minister will call this. Believe you me, today, that shivering is missing. And then we still want to use that. That is the only language government understand. Strike is the only language government understand. Government is dumb, oh. They know they understand that language again. Will you not devise another language? Will you not? I personally wish to commend FCT that 8 years, no strike. But a lot of things, so many arrears were paid. Even some of the federal hospitals, they were not paid. But FCT paid. Many states are still struggling for level 17. Most of the federal hospitals, I think it's not more than 3 or 4 that the HOD nursing are on 17. I can tell you categorically. But you have so many people on 17 and without strike. I don't know whether you understand. So there is a proverb in Hausa that when the drummer have changed the sound of the drum, the dance should change. But Jehesu, the drummer have changed, the dance was still the same. So strike. You know, before government was not doing no work, no pay. You still go on strike, come back and collect your salary, or continue to collect your, see your alert. Government decide to say, even if it's a 7-day strike, they will remove it from your salary. Even if it's a 3-day strike, well, they will remove it. And if you insist, member will say, when are we coming back? And the union will say, let's meet to review. And you know, like our own, we have procedure for strike. Do you know that a unit of Nannm have no right to go on strike without approval? I don't know. Today I'm not talking on strike, but I feel it's important. I highlight it. Assuming, let me use my friend here, Api, National Hospital. They have meeting. They want to go on strike. Those things that you want to go on strike for, any communication you are doing with your unit management, you will be copying the state council. So at a stage where you feel you want to go on strike, you now inform the state, we have exhausted all the avenue. We want you to take over. The state will now write the national for approval, having come in, that now we want to declare nurses strike at National Hospital. National will give them approval, and they will declare the strike. So that the management there will not be intimidating our ESCO there. Anything say, no be also, now state declare. So they are fine escape. Are we together? Many of these unions don't have that procedure. They don't have state councils so formidable like our own. So when this strike was done haphazardly, the government will go and meet one NGO. The common one they use for us is they call it Kingdom of what. Those of you in federal, you know. Kingdom of, that's one NGO, Kingdom something. In fact, they used that same NGO recently for ASU. They used that same kingdom something. When ASU have this strike for almost 8 months, they used them to take them to court in public interest in that. And that was the same kingdom they were using against Johesu. At a point, we had a very sharp issue. One was to commence strike, government wanted to act on it. At the end of it all, they came and said, government want to scrape the unions. And you look at the labor law, procedure for scraping the union, government cannot just come overnight and say, I have removed Nannm on register. It's not possible. So while some of us are saying this is not possible, some are saying, because our own, we are also a professional association. You can't scrape professional association. But you can decide to scrape trade union, like NLC, you know, at a point they put military administrator. You can't do that for professional association. Are you getting me? So this one became real problems. So members were feeling we are being used, we are not achieving what is happening. In fact, our scheme of service, we had to fight it alone. I remember in 2013, we fought it at Ilorin. It couldn't scale through. We spent money. It was in 2016 in Mina that we achieved it. And when the thing came out, it came out with little fracture. That our intern should enter on GL8 instead of Cohes 8. And for pharmacists, for lab scientists, all their intern enter on what? Cohes 8 is only nurses. And yet we are Johesuing together. We are Johesuing together. Why should your own? Because for intern pharmacists, it has been there for some time. For lab scientists, they use us and rose up so fast. And we couldn't get it. And what was the argument? Oh, okay, let me rush. What was the argument? You see, nurses are not graduate. We are graduate. Those of you who go for BNSC, how many years? 5 years. A lab, how many years? 5 years. Pharmacists, how many years? 5 years. For generic. Plus internship, 6 years. Plus NYC, 1 year. So what is the difference? Why should there be difference in remuneration? Those of you who run calls in the theater, you remember 1.68 against 2, against 4. When I say that, those in the theater understand what I'm talking about. So we could see that at the end of all this marriage palaver, nurses were losing. Left, right, and center. Technically and otherwise, nurses were losing. So there was a lot of mistrust which can be rolled out in any organization anyway. The heterogeneous nature of this organization, JOHESO, have raised serious concern and critical observations as to its effectiveness, justice, and fairness in the representation and addressing members' needs. This has consequently led to a call from some members of one of the most significant components of JOHESO, that is Nannm, to withdraw from the amalgamation. You know, for long, nurses have been calling for it. In fact, in April 2021, the National Executive Council of Nannm met and resolved in that meeting that Nannm should come out of JOHESO, April 2021. But we were still foot dragging gently, let's look at it, let's analyze pros, cons, whatever. So all those analyses were done until April 2023, 2 years after that next decision, before we finally say we are pulled out. So that it's not done urgently as if with the aim of creating problem. I remember the COVID allowance. If you observe, negotiation for COVID allowance did not take up to 1 hour with government. You know the secret? That time we were having Nannm A Nannm committee to look at the health sector. I represented Nannm on that committee. And we educated a lot of doctors to know that there have been injustice meted on nurses. Honestly, I remember Dr. Avidimi from Zaria, Dr. Izet Abdurrahman. There's the CMAC of Gogola. That was the name again. Tamlong from Plateau. He was on that committee. Who are from National Hospital? Dr. Henry, pathologist. He was that. Dr. Joyce. I mean, a lot of them we work with. We were able to represent you and explain to them why this injustice against nurses cannot be accepted. That was why we formed a small committee, 9 members, Nannm A, and pharmacists. We went to Nannm A secretariat. We meet and agree on the COVID allowance before we went and faced government side. Less than an hour, we have agreed, agreement signed. JOHESO chairman arrived, we have finished agreement. Wallahi. That was why they begin to attack. Admin people are not this COVID. I know some of you know the politics there. Because we have already done a lot of homework behind the scene. But people to know, you don't need to argue on the value of a nurse. Honestly, if it is healthcare delivery. But see us being relegated. Somebody is calling you degree and degree. I mean, are we saying we don't have degree? Your chairman is having PhD very soon. I have masters. People see professors, see everywhere, and you are telling us no degree. I cannot understand. And do you know that JOHESO is still banging on that in their arguments? That's why we say we better come out from among them and be separated. Honestly. You know. So those were the situations that were happening. Emergence of Nannm. How did Nannm come to be? In 1977, at City Hall in Lagos, there were 15 unions in the nursing profession. Different unions, they came together and formed Nannm and established Nannm in 1978 following the amalgamation of about 15 professional groups within the nursing profession in Nigeria and recognized by the Trade Union Amendment Act of 2005. It is that good. These are some of the unions in 1957, Patnon, this one, NNA, so many unions within the NAM and among nurses. So we had to unite and came up with the disunity among nurses became more pronounced in the Udoji Award in 1976. They sang discordant tunes on issues of their common interest. And so they lost out. As a result of that, they come together and say, united we stand, divided we fall. This is our logo. This logo, you don't know how important it is. It is very, very important. You won't know until you use it to do something and you go to jail. Now, NAM was now put together and was registered in 1978 with official registration number 0011. It was formed for the members of the nursing and midwifery profession in Nigeria to speak with what? One voice, and to work for what? Common cause. One voice, common cause. That's the essence of NAM. Area of the jurisdiction, whether you are in private clinic, you are in federal, state, local government, all is the same. Now, implication of NAM exit from Johesu. With Johesu, there are problems, and without Johesu, also definitely there will be problems. True or false? True. But there are no problems without solution. After leaving Johesu, NAM is now left with two major implications. One, stand alone and fight our cause. Two, sporadically collaborate with other unions, e.g. Nannm A, for mutual benefit of our members. If you leave Johesu, you have two options. You stand alone and continue to fight your cause. Or sporadically, that is on and off, you can collaborate with this, achieve what you want, leave. Collaborate. That's what we call JAC in those days, Joint Action Committee. Either of the two options will come with its own challenges. For instance, questions like this will come to mind. Can nurses stand alone to fight a battle? Can nurses stand alone to fight a battle? Are we together? Are nurses bold enough to face management of their institution or even government of their states or nation? When the heat is becoming unbearable in a struggle, like no work, no pay, are they ready to remain steadfast or even damn the consequences? Are you getting me? These are questions that should come to our mind. Are we ready to stand? Come sun, come rain. We must stand, damn the consequences. I was in the clinic 2007, 2008. One Baba just came, one messenger came with a letter. He was asking my staff, where's your Oga? I was heading the ENT clinic. They say, he's in the office. He came. Sano, and that is, I should sign. So I signed my name. I saw the letter. Your services is no longer required. And what was the reason? We were fighting for 100% cohes. Because government gave only 40. Later they changed it to 80. We say, wallahi, we no go do. Grammar upon grammar. And I wasn't even an official in the state council. But they told them that all that they are doing, I'm the brain behind it. So that was my fault, that I can write and I can mobilize the nurses. If I tell them, go and burn this place, they will do it. So it became an issue. They terminated our appointment. But I was laughing. We were celebrating. Nurses were crying. We were celebrating it. Because I told them I'm happy that I'm worthy to be terminated for the sake of nurses. Honestly. So it was big drama. We declare Operation Total Paralysis. All the hospitals, we locked the gate, no worker, nobody. We did that for just 6 days. Government had no option than to bring us back. But today, if there is that heat, are we sure we can stand it? Or is it the branch secretary who will go and meet management? Now, chairman, no, we didn't want to go. Chairman in our ESCO, he insisted. Or the PRO. So these are questions that are very, very important. Are nurses as united as other professional bodies when it comes to fighting for a cause? Won't the intra-professional bickering serve as a major hurdle? These are the questions, some of the questions begging for answers. On the other hand, if now join hand with, let's say, Nigerian Medical Association, would they honestly accept us with every sense of selflessness? Can we have equal stake in a relationship we want to establish? Can we pose same threat to Nannm A in case of any foul play suspected as we pose to Johesu? If the amalgamation between us and the doctors collapse as it did with Johesu, can we go back to our vomit? Good. I'm happy. In my opinion, nurses and midwives can stand alone with efficient, courageous, and selfless leadership. Efficient, courageous, selfless leadership. Tell your neighbor, with what? Efficient, courageous, and selfless leadership. We can stand alone, let me tell you. We can make it. We can win our battles for ourselves. The first thing to lose in a fight before losing the fight itself is what? Self-confidence. When you are already feeling defeated before you start, you are defeated. You are defeated. So nurses and midwives should feel highly, highly important and can stand alone for their fight. Nurses are key players in health promotion and disease prevention. That is the strategic task ahead to achieve investment. Nurses work on the front lines of disease prevention, health promotion, and so forth and so forth. Despite the critical role they play in healthcare, there is nursing shortage across the world that will affect the delivery of competent nursing care. True or false? Yet, to enable the full contribution of the nursing workforce towards the achievement of universal health, there must be a strong, strategic, and sustainable increase in investment in the nursing profession. These are just facts of the matter. For our time, you will read that. The following are the strategic investment areas in nursing. Number one, education. Nursing education, professional development, personal professional development is key. We must invest in nursing education. The former HOD of FMC, Kefi, Malam Adamu, who is now is a chief, I think, just from Nasara. Adamu now, former HOD, FMC, Kefi. At a point when his nurses were going for exams, this child was, they'll go in buses, 2 buses, carrying FMC, Kefi, because he makes sure if you are going for training, release, approve. Sometimes you tell MD, this one for my sake, allow this one. Let them go. Believe you me, the pursuit of education among nurses cannot be overemphasized. Assuming you are doing ward round, and the patient asks, doctor, what is your name? The doctor say, well, I'm Dr. Bearden. He said, nurse, what is your name? I'm Dr. Margaret. Yes, they don't have PhD. They don't have MBBS. You know that when you are going to argue on management of a patient, doctor argument, brain argument, then the patient will have respect that the person who is talking to me is a doctor, not what they refer to, they say ordinary. You know, I don't know what people mean by that. Ordinary. You know, I remember at OAU, our first professor in nursing, Professor Jinaidu. Professor Jinaidu, some of you, have you heard of his name before? When we met in Jos, and they heard that Professor Jinaidu, they say, what? So nursing also get professor? Baba Jinaidu. He's the first nurse professor in this country. Today they are nyafu everywhere. So struggle, be a professor. So that, and you are still doing your bedside nursing. When they come to talk, they say, well, these are registrar residents, this doctor this, I'm professor. What's your name? Anibeze. Prof, don't invite your one is Prof Anibeze. That is it. So education will take us where we're supposed to be. Do you know that when you even argue intelligently, people will begin to doubt, is this one a nurse? I don't know, have you not observed that? You know? So, but when you are still talking was to, you know, to was, there will be problem. We need a lot of leadership. A lot of leadership. I tell people, a leader is someone who knows where he's going, inspiring his followers to follow him, or the followers are following him or her without compulsion. That is a leader. That is a leader. Give them the information. Let them follow. Let them follow. So we need to provide leadership. Those of you who are AD, DD, whatever, DNS, you know. And leadership is only not for AD, HOD. If you are nursing officer 2, this one is nursing officer 1 or senior nursing officer, provide leadership. Provide leadership to nursing officer 1 and 2 as SNO. If you are PNO, provide leadership. 5 minutes, don't worry. So, jobs, service delivery. Now, this area of service delivery is my major problem. Are we providing the service? Are we providing nursing services? Because those are the things that will help us when we want to stand alone. I've seen management approving something for state. They say, because of you, I will approve. Even in your unit, you want to go for workshop, say, your MD will see the list and say, because of, what's your name, madam? Uchala. Because of Uchala, I will approve. But you are a union ESCO, you don't go to work. If they hear say they don't distort patient money, you there inside. They fought on duty. Now Uchala. This word, there was no nurse around. And then the patient fall on bed and injure. Who was on duty? Ochala. Believe you me, service delivery is a key. So I've talked about this, so we just try and conclude. Intersectoral actions with other people, government should do this, NAM should do this. We'll just go their leadership, I've talked about it. Now, health labor market conditions to be analyzed for their capacity to accept new graduate nurses and retain current nurses. You see, NAM will have a lot of things to do. Are we together? We'll not just stay alone. interprofessional and multidisciplinary collaboration between the public and private sector should be facilitated so that we really work hard and improve what we are doing. The roles of nurses should be clearly distinguished in both legislation and practice. You go to federal hospitals, they will tell you passing of NG tube is not nursing duty. But in your training, you are taught how to pass NG tube. Catheterization. Are you getting me? 2003, I went to ABU there for cancer exam. The first thing I asked the nurse, I saw a patient needing NG tube. The tube was there. I said, go and pass. So they were busy talking, everybody. So they now tell the senior nurse, talk to him that it is not done here. So I insisted that candidate, I said that's the only procedure I want her to do. They were already afraid. And this candidate, they know how to be very intelligent. She will just fail, oh, how good. Everybody, I could see them talking. I insisted. So she went, she said, I pulled off my coat, put on glove, directed her. She was putting, she got it. I said, what do we do? She said, okay, let's get water. I said, no, water is outdated. If you put water, they will aspirate to the respiratory tract. Why is syringe? She pulled off. We saw gastric content. I said, is this not gastric content? She was happy. I said, oh yeah, attach it, this and that. Then feed the patient, document it. During the exam, I did it, and I guided her. So the HOD came. Hey, who did this? I said, it's my student. Chief, when have we started? I said, don't go there, please. Don't go there. Don't go there, because if you go there, you won't get it well with me. So after that council exam, I went and met the CMD. Why are you doing like this? You will be traveling to Yola. I'm not praying for accident. You'll have accident at Alkaleri. This nurse, you are refusing how to pass NG tube. You will come with very big distension. She will be the only one on duty. She has never practiced passing NG tube. She won't help you. You will die there. So allow them to practice what is in their curriculum by the Federal Republic of Nigeria. That is it. It's in the curriculum. So all the areas we want association should intervene, push for the followings. Government should develop and maintain centralized health information system, and so forth and so forth. Equitable access. Standing alone, we'll conclude here. The fact that standing alone is the best option, we have a lot to gain in this. We shall reposition ourselves. Isn't it? Let's reposition ourselves. We shall find our lost glory. True or false? Yes, we shall find our lost glory. We shall be a force to be reckoned with. We shall have time to take our destinies in our hands. Not for you to go on strike for 7 items and no one item is benefiting us. We shall be able to focus on the factors responsible for our intra-professional bickering and look for a way out. Now, in conclusion, there is no perfect professional body, group, or individual. Everyone has his own challenges they are contending with. We nurses and midwives should reason along to save the profession from needless distractions by valuing the profession and the association. Our professional body, Nannm, should be, on the other hand, emphasize personal professional development, trade union education, nursing image laundering, and better nursing services to our clients and the public at large. If you forget all I have said, just hold this one, this last one. We should emphasize what? Personal professional development, so that Ochala, Filade, they will all be professors. Are we together? And still working on that patient on the ward. 2, trade union education. Many of us don't know this trade union education. They don't, in fact, some don't even know the difference between Nannm and Nursing Council. So we need that. More trade union education. In fact, Nannm is going to make it compulsory. Any workshop of this nature, at least there should be one presentation that has to do with trade union education. You'll get the circular very soon. Nursing image laundering. Do you know that many people are not rating us correctly as who we are? Somebody would hire a story on the street and say, they say when women want to deliver you, they slap them. He has never known, no. He only had somebody saying it, and they will be quoting it. There is what we call therapeutic slapping. Yes, I was making a presentation in Calabar. I told them, everybody was there, the governor, the former governor, all of them. I say, which one be therapeutic slapping? I say, sir, you are an elderly man, you have your daughter-in-law. Your son, your firstborn married her. 1 year, no child. 2 years, no child. 3 years, no child. You are already blaming witches and wizards responsible. On the 7th year, see pregnancy. This woman now is in labor. When the head is crowned, my friends, midwife, wise women, you understand? When I say when the head is crowned, and the woman close her legs, will you not therapeutic? And when you have finished your therapeutic tapping, the baby comes out. Hey, you give the mother. Do you know where we miss it? At the end of all your therapeutic, you don't explain to them why you did that. And that is why when they go home, these midwives, I will never deliver in the hospital again. They are wicked. They will go to hell. Because you didn't explain to her why you slap her, if necessary. I don't know whether you understand. Some will even threaten her. You must deliver, oh, you must open your leg. If not, you see, we'll not leave you here. Nobody is here with you. It's only us. This and that. Because this is a primary that sub-language at that stage, she may not understand. Like now we are talking, and there is a snake that is coming. This snake is about to bite her, and I just push her. Will I have time to say, you see, you need to... But then that snake will bite her. But if I push her and the snake did not bite her, after I explain to her why I push her. That is what midwives do. And the society are just busy blackmailing us because they don't know. They are not midwives, they don't know midwifery. So it is you who will tell them, after your action, there should be explanation. So we need that for our image laundering and better nursing services, better care, better nursing services. Do you know that even madman knows care? If you have a madman near your house, just be giving him bread and tea. Do you know that this madman, if somebody wants to beat your children, and the madman knows these are your children, the madman will beat that person. Talk less of a sick person that you are giving him good nursing services. Like my friend, the MC, if he's admitted in your hospital, you take good care of him in the morning. How are you feeling today? Have you heard from your family? Will you not like even always to go to that hospital? Believe you me, if we work as nurses and midwives, we don't need any strike. We will achieve. I was in one of your programs when the former FCT minister, just a minute, former FCT minister said they brought a patient in the hospital. He gave 2 stories, the former FCT minister. He said he was for circumcision. You remember those of you who are there at International Conference Center. The way and manner that nurse was talking to him before he realized he slept up, only to wake up and find pain. And then he has a relation too. They wrote drug for 1 month. The nurse told them, buy for 2 days first. Let's see how far we can go. And the drug was expensive in Yola. So they bought for 2 days. The patient took for 1 day. Before the second day, the patient had died. So he said for that, he has high respect for nurses. They know what they are doing. If not for that nurse, they would have wasted their money. So with good services, we shall overcome all this discrimination against nurses. I'm telling you. Can we stand alone? Can we stand alone? Yes, if united. Because united we stand, divided will go. Thank you for listening.
We are very grateful. Please, may we appreciate him once again, ladies and gentlemen. Yes, in this, we have truly benefited from the fountain of his great knowledge. No doubt that he was the national auditor. And no doubt, even when he left services, he is still in services. I think language is very, very important. Just like he said, if Snake is about to buy this and he rushed and pushed her, and maybe she got an injury, the injury and the snake bite, which is more grievous? The snake bite. So it's better to have the injury. You understand? It reminds me when I was in Kano, this Igbo woman doesn't know how to speak Hausa very well. And the blind man was doing like this, coming, and there was a very big sock away. The Igbo woman said, "Amat mekafo, ka koma tofi ankaya karefa. Ka koma tofi ankaya kare." I mean, when he was approached, meaning, blind man, your journey don't finish, so make you go back. So now the blind man was just, he said, "Tofi ankaya kare." What did be that one? Before you know, the guy fell into the sock away. He said, "Tunda mamunga mamunche tofi ankaya kare." Was it achieving? So sometimes I agree with your ideologies. You know, sometimes I'm a friend of the lawyers. If you are a trade union man, you must be a friend to a lawyer. Because we have been picking it well with lawyers. When Oga was saying therapeutic slap, there was an echo from the Temple of Justice that's battery. And when I critically analyzed the face of that very member of the Temple of the Justice, I said, no, the language he used is the right language. So, exactly. Because if you don't do it that way, there will be no good result. So that is why, by the grace of God, I am a nurse today. Those who are for said I don't against said nay, the eyes have it. Thank you very much. Because if I allow you to debate too much, thank you very much. We have truly benefited from that. I want to add this way. Please take note. United we stand, divided. The second stanza, sorry, the third stanza of the Solidarity song that says, "Is that aught we hold in common with the greedy parasite who will lash us into serfdom and then crush us with his might?" Then the second stanza says, "They have taken untold millions that I never toiled to earn, but without our brains and muscles, none a wheel would have turned." Do you understand this? I'm trying to connect you with that united we stand. See reason to it. He said, the other one said, he said, "In our hands is placed a power greater than their hoarded gold, greater than the might of 10,000 armies. But a day will come, we will bring to birth a new world from the ashes of the old." So that's exactly what he said. Please let's put our hands together for that very presentation. Yeah, when I saw the name of the next presenter, I said, yes, I met her somewhere. When I met her, and she will know, I'll remind you today, we met in the airport. Then too, I was traveling to the States. She was traveling to Dubai. I mean Kaduna State. Well, very distinguished ladies and gentlemen, we have a very wonderful topic today once again. Nursing practice in Nigeria and its legal implication in the 21st century. This is very interesting. Because let me tell you, I told you yesterday that the Ministry of Labor organized a workshop, I think 2 or 3 weeks back. The president of the Nigerian Industrial Court, National Industrial Court of Nigeria, he was the one that he came by himself and then presented a paper and gave us a lot of overviews about some legal implications. The mistake we make as trade unions. We forget a lot of things that would have helped us to forge ahead. That we have a lot of opportunities, but because we lack the principal knowledge of the legal implications of certain actions. But today, we'll definitely add more value to our own understanding in terms of trade unionism, legalities. And no one can ever give us this. No one, I mean no one can ever give us this that would make us actually being endowed, except this very particular legal personality. Well, but before then, I wanted to say this, before I invite her, that between a driver and a policeman, who is more intelligent, who is more legally intelligent? Please be very fast about it. Between a driver and a policeman, who is more legally intelligent? Police driver, okay, no problem. Let me serve as a judge. You said driver, I said a judge. This day, one driver was driving from Maiduguri to the east. He arrived, the eastern part. The police stopped him. He said, where are your particulars? He gave the police the particulars. Then the police went through the particulars and said, please, driver, your particulars are not correct. This guy jumped down from the lorry. He said, hey, K. Malang, I drive on for this motor, the Maiduguri. I pass on through Abuja, where wrong something, and BIO, they plenty, they confirmed that my particular car was correct. I passed through Okene, where there are police too, and everybody get trouble. They confirmed that my particulars are what? Correct. Amadang Allah police for you for here. You said that my particulars are not correct. To go buy or correct, why it's not correct, and give my particulars, make I go. Hello? Hello? So meaning the particulars of the next paper presenter is what? Correct. Thank you very much. May I invite with all sense of dexterity and legal honor our very, very dear own Barrister Helen Malika Gizo. She is a very, very intelligent and brilliant legal practitioner. Though I am also a lawyer, she was called to bar, I was called to the bar. So she's a member of the bar while I am a bar member. She addresses her colleague as my learned colleague, where I address my colleagues as my skillful colleagues. Thank you very much. Let's put our hands together for ladies and gentlemen.
Thank you. Good afternoon, ladies and gentlemen. And in the voice of our one-time First Lady, former First Lady, Patience Goodluck, my fellow nurses. Well, the nursing profession is a very, very important profession. Honestly, I would have loved to be a nurse. Honestly, my family, I have nurses as siblings, even as a parent, I have a stepmother as a nurse. And I happen to just, be in the profession so well because of my upbringing. So I love nurses. And the former speaker has made my job very easy for me. When I was coming to deliver this paper, I said, what am I coming to say about the nursing profession? But God has a way of doing his things. The former speaker just made it easy for me. So I will try as much as possible to make this thing very interesting, because he has highlighted everything concerning the nursing profession. And he was breaking it down. I was hearing Jesus. But the most important one is making it nursing practice, as in stating how important, how a vital component it is in the healthcare system. So don't please downplay yourselves. And I think the most, the problem we have most is that a lot of the societies do not know the roles of nurses. Honestly, if they know the roles of nurses, this hierarchical structure, that traditional hierarchical structure of doctors feeling more superior than the nurses, it won't be taking place. So I think I will just go through my slides and rush down to the basic, the most important aspect of the paper, which is practicing nursing in Nigeria in the 21st century, and then its legal implication. And then we'll drive all through the laws governing nursing practice in Nigeria. I hope some of us know, because we're going to be, it's like going to be an interactive session. You help me, I help you. So, let me go through the slide. I don't need to run through the background. Like I said, the earlier speaker has done all that, but there's no how I will have just jumped into the legal implication without laying my foundation. Yeah, so in laying my foundation, I have to talk about the nursing practice in Nigeria the background continues, then the nursing practice in the 21st century. Let's start here. So like, you can't compare the nursing practice in this 21st century to like the last century. It's dynamic and it's evolving. And there are factors that necessitates, or that is evolving due to some certain factors. And what are these factors? One is the advancement in technology and the equipment you use. They are now, like, I remember especially this BP apparatus. We used to have the one with pump and pump, even though we still say it's better than the digital one. I don't know how true is it. But things are not, with the, even with this artificial intelligence, with so many things make easy, we have to upgrade our system, our education, and even the practice in order to meet up with the 21st century dynamism of the profession. So, and then another aspect of one of the factors for the advance for the practicing of nursing in the 21st century is one of the other factors is the changing healthcare needs of the population. Everyday diseases come up. I think of recent, I've heard something like diphtheria. So it changes. We had COVID some years back. I think even in the, up to now, it's still in some places, you still hear about it. So this 21st century, you cannot, nursing profession is not something that is static. As you go by, that's why I said it's a very vital component of the healthcare system. The former speaker said, if there are no doctors or the lab technicians or something that are closed, you will still find a way of doing investigations if the nurses are on ground. If the doctors are not there, you still find a way of the patient being taken care if the nurses are on ground. So that is why the profession is not static. It's a very vital, is a vital component, something that keeps evolving with, you know, it keeps evolving. Then I'm sure you people know, you will teach me better on this evidence-based practice. It's something that is of the 21st century. I don't know what it is. Can I be enlightened, please? I don't know what it is. I just read it. Reading it, I'm hearing anything, I'm seeing something like, you need to ask questions. When you ask the questions, you make some appraisal. After the appraisal, you get some outcomes, and then you apply. I don't understand. I don't know if somebody can teach me, please. When I get to my own level, I also know that at least I can be a teacher in that field. But this particular one is you that should be able to teach me on that. Mommy, Sisi, sorry. How are you?
Oh, I'm mommy. I'm even grandma.
Oh, yeah. Then that's good because you look younger than that, actually. It was just, you know, this weed, I have this size. It was just the size I saw. I said, mommy. But when she turned around, it was Sisi I saw.
I'm close to 60. Yes. Thank you very much for...
So please, I just want you to enlighten me on this evidence-based practice.
All right. Well, we are the old school. We're trying to climb the ladder to be at where nursing is practiced by evidence-based. What I understand by evidence-based practice is using the tool, the nursing process tool, which is recognized worldwide, internationally, to assess your patient from the time he or she comes. And asking the clinical questions? Is that what it is? Not really. The patient might not be able to talk. Your own assessment, as soon as you see a patient who is gasping or fighting for air, you begin to suspect that this patient is an asthmatic or something is wrong with his breathing. So that is an assessment. So you now think of what to do for the patient. After assessing your patient, you now give a nursing diagnosis, then you give you think of, you plan on what to do, and then you implement what you have planned. Then you assess again and see the outcome. If the outcome is positive, then you know that you have achieved something. If it's not, then you go back to the drawing board of another planning and implementing something else. So all what you do is evidence-based. You see it. You see the patient progresses as along line as you implement. Thank you.
Thank you. Honestly, that's a good one. The former speaker will also help us. Thank you.
Now, as you said, evidence-based practice is a modern approach. Evidence-based practice is a practice where it's based on knowledge, research, approach in managing a client. Away from the traditional method of, I was told to do it. This is how we have been doing it. But this one is a study, you are knowledgeable, you have researched into it based on this, so you are practicing, you are giving the care based on the body of established knowledge. It's not assumption.
Thank you very much. That's why I said God knows how he does his things. He arranged the speaker, you understand. So thank you for helping me out. Thank you, Grandma. I appreciate that. I'm not going to go to the next slide. I want us to do this. I want to see how enlightened we are with the laws governing nursing practice in Nigeria. This is a bonus. At least you are in a profession, you should know which laws are guiding your profession. Auntie me, you know, I got approached to you when you did your so I believe you know one of the laws. Just one. Okay. Please, who can help us? Who does your licenses? Which organization does your licensing? What? No, the organization is not Mr. Filade I'm talking. Which organization does your licensing?
Nannm A Midwife Council of Nigeria.
Thank you very much. So that is just one body regulating, just one of the laws regulating your nursing practice in Nigeria. And what does the NMCN, you know, is set out, I learned it set out the rules, some high standards of practice. It does your licensing, the renewal, and then it also met some disciplinary measures on erring ones. That is one. That is the bonus I was saying. But there are other laws guiding nursing practice in Nigeria. One of them is the Criminal Act. Another one is the Child Rights Act. We have the Freedom of Information Act. The National Health Act, we've talked about the NMCN. The second one, the National Health Act, encompasses all the stakeholders. It's not just the nursing, but the nursing is part of the healthcare system. That is why this act is also applicable to you. So the Criminal Code Act, this one does not directly state the nurses in the act, in the provision of the act, but it defines various criminal offenses and their penalties. And one of such criminal offenses is the act of negligence, which we know that a lot of my fellow nurses, you know, we have so many cases that we're all guilty of. I don't know, the law prescribes, there's what they call it, what is it? It's negligence too, but they call it, let me see. What? No, not maliciousness. There's a word that negligence is something that you unintentionally do. There are cases of forgetting to probably regulate the drips, or you give the wrong doses of medication, or you forget some tools during the operate in the patient, those are acts of negligence. You understand? You unintentionally do those acts without, you understand? But there's another word I'm trying to remember where malpractice, thank you very much. Those one you willfully and knowingly, but I'm still finding it difficult to understand how somebody will willfully and knowingly do such an act. No, honestly, patient under your care and you will willfully and knowingly, when we go through the slide, you actually see some cases. Some nurses found guilty of those malpractices. Negligence, I can understand. We are human beings. But that is the law, and some people are found guilty of. When the former speaker was talking about therapeutic slap, and I mentioned battery, I was happy he qualified his statement by saying, when you explain. That is where we'll come to Freedom of Information Act. It's also a law that, guides the nursing practice in Nigeria. Please, my fellow nurses, at this 21st century, you discuss with your patient. If you're giving your patient an injection, hello, ma'am, this is, paracetamol, 5 milligram, 2 milligram, I'm about to give it to you. Information, it helps. This is a beautiful profession, honestly. But like I told you, let's keep sentiment aside. You see some nurses, I know we all have our problems. We all come with heaps of our problems, but we should try, we are human beings, to drop it whenever we want to. They are not ready to communicate with you. Doctors, if I go to see my doctors, in this area of Google is your friend, Google is the witch doctor, when you tell me this, I'm sorry, all we need to be polite. I'm sorry, doctor, what do you mean by this? And with those, they are draconian writings. When they write, you don't understand what they are writing. So you, the nurse, if you can interpret it, help the patient. This is what, in those days, they prescribe drugs for you and you don't know what you are being taken. You take to the pharmacy, what the pharmacy gives you, you go. You don't get it. But we thank God for the Freedom of Information, which is another law. When they ask you, the Child's Right Act, I'm coming to that. The Freedom of Information Act. When they come and ask you, you must provide the information. Even the one that it might seem like violating the rights of the patient, the one of privacy and stuff. So far the person goes through the procedure of the Freedom of Information Act, you will provide. If there's a matter and it goes to court or your NMCN is handling it, they will ask for, they can write to any hospital, like write to DIF. We need information on the way this patient was treated. You must provide it. The patient itself will say, I need information from the beginning of my folder, my file, to now. You will provide it. So this is a very important aspect of, and this is not applicable to nursing alone. It cuts across, even the judiciary, the educational sector, or it cuts across the Freedom of Information Bill. I think it was during the Obasanjo or something like that it was passed. So it's a good one. The Child's Right Act, one of the rights of the child is the right to health care. So the child can sue through his guardian if that care is not being given. Or if the child is in your, some of you that are in the pediatric ward, don't think it's because it's a child you're treating. That child has the right to be treated well, and he can enforce his or her right through the Child's Rights Act. The Patient's Bill rights. This right was promulgated by Consumer Protection Council in collaboration with Federal Ministry of Health. And it has series of different types of series of rights down to receive information about his or her treatment. A patient has that right to also receive care that is safe and effective, to have privacy and, and confidentiality. Then I said it would not be fair if I just discuss, these laws guiding you, the profession, without discussing your challenges. But I'm happy that the previous speaker touched on some of these challenges. We'll just run through them. Inadequate staffing, inadequate resources, inadequate training and education. He also talked on how to, you people are encouraged. Quite all right. If you have inadequate education, you're bound to have a lot of lawsuits. Because if you are highly educated, just like he has said, you will know what you are supposed to do at the right time. So it will mitigate a lot of lawsuits that are flying around against nurses and their hospitals. We have another challenge is the law. That one is not just nurses alone. It's almost every aspect, except probably some organizations and the politicians. If not, everybody is complaining of low pay now. Then lack of recognition and respect. We have that one. We have that problem. And I thank God he also talked about how we can, beef up our self-esteem, and enhance our CV by, schooling, so that we can do away with this traditional hierarchical structure of probably doctors better than nurses, Then we have cultural beliefs and traditional spiritual beliefs. Is part of the challenges we have. Nurses will be trying their best. In as much as you're trying your best, there are some that come with their beliefs. No, don't do this until the matter gets worse. And then you have to give them that respect because it's contained in the patient's bill's right, that you should respect their beliefs and culture. But no, in doing that, it poses as one of the challenges because some will tell you do not take blood transfusion, it's against their beliefs, and you see the person dying, and when you try to do that, lawsuit will be slammed against you for violating the patient's bill's rights. So I'm coming back to the legal, when I was talking generally, to the legal implication. We have talked about malpractice. There's a case there of Madam Ngozi against Federal Medical Center Owerri. I think she said she suffered from severe pain and swelling because the nurse had administered an injection that she was not supposed to. So of course, she sued and, damages were awarded against the nurse. Then act of negligence, I've also talked about that. One Mrs. Felicia Ogunleye also sued the LUT, Lagos University Teaching Hospital, and also judgment was in her favor. Then violation of patient's right, like what I have just discussed now. One of the patient's rights is respect my tradition, respect my cultural belief, and then you violate any of this, like this case of Mrs. Oluwakemi, where she said the nurse violated her patient's right. She underwent a surgical procedure, and the nurse failed to probably monitor her after the surgery. And it's her right to be well taken care of. And the nurse did not do that. She also was given judgment in her favor. Then another legal implication that you can be sued upon is when you fail to report where there are cases of infectious diseases. You understand, like during the time of Ebola, because someone is a relative and the person is having the symptom of Ebola or COVID, you don't want the person to be quarantined and you keep quiet. It's an offense. And, you can be taken upon. On licensing practice, you know it very well. You don't renew your license, it's an offense. You don't even go for the correct procedure for the documentation for the license, it's an offense. And there's a case for that. Then during the course of this research, honestly, because of the way I love the profession, we've just been discussing about the legal implications and the lawsuit. How is the nurse protected? Because it's just been, they take you to court, you know, you do this, there'll be a lawsuit slammed against you, you do that, negligent, do that, you know, malpractice, do that, you're violating the patient's right. How are you people protected? No, not exactly. You answer me. It's a question. You answer, how are you? You should be bothered. Which law? What are your rights? Do you actually have rights? As a nurse? Okay. So one of them, please. What is that organization or the body that gives you? Is it the NMCN? Nannm. It's not an act. It's just an association. It's not a law.
Though I'm aware that we nurses also have a right to attend to the patients that we want to attend to. For instance, if I have a patient who does not like me, yes, as a nurse, for any obvious reason, I have the right to report to my superior, whoever is there, that I don't want to, this patient may implicate me, and I'm giving him or her a wrong medication. So for me to run away from such, I remember I did that, and there's a law that was even pasted on the corridors, our own right. I can't remember vividly now, but I know we have rights too, that I can't remember in details.
Okay, thank you.
I think sometimes the facilities where you work have a way of protecting their staff whenever there is an issue. So, like in our facilities, we see where if something happened between any of the staff, the hospital would take up. Yes, the hospital management.
I'm talking about the hospital management. I'm talking about a law, an act that protects nurses. But
what I saw is not only for nurses. It's for all health, for all civil servant workers. It's called Health Act 1970. It's a public law. What I saw on the internet.
You might be making a lot of sense. You still want to talk?
Well, apart from the Public Service Act that I know, apart from the Public Service Act she mentioned, I think the only thing that protects us as nurses is our documentation, our own personal reports. That's the only thing I bank on in my place of work. No, the reports you do at the workplace concerning everything you do to a patient and your professionalism at work, that's the only thing that is protecting me personally.
I will agree more with you. I'm not saying I'm not agreeing with you. You know, every day you have, from the beginning I said it's going to be an interactive session. I will look into that law, but directly to this one settles what I'm trying to say here. You know, the NMCN gives or states some high standards of practice. And if you follow those standards of practice, that protects you. That is your protection as nurses. So it's now behove on you to work hard to live up to those standards, you know, listed by the NMC or is expected of you by your organization. Then another advice I will give is probably you will pick up a professional liability insurance. Yes. In case of any lawsuit, they can provide representations. They can provide probably financial aid in as much as you pay your premium yearly. The NMC protects you people indirectly by setting those standards. And when it even happens, you see they don't just leave the nurses. They conduct investigations, you understand, and they also conduct hearing. I believe they conduct hearing, and they try as much as possible, depending on the circumstances of the case, you understand, to protect the image of the nurse involved. If when the circumstances, the evidence is too glaring, there's nothing they can do. Even the insurance that you will go and be paying premium, if you know insurance, they will even make sure they show you paper, where they will not even defend. Look for a loophole where you're lacking and say you can't claim that insurance cover. So please, to round it up, I don't want to overbore us, is that in as much as the NMCN will, and the financial and insurance, this thing is likely to give us some level of support, the circumstances of the matter differs. So please, let's leave off to the standard set off by the MCN, NMCN, and by the special grace of God, all these lawsuits will not come our way. Thank you very much.
Please, can we put our hands together for that, ladies and gentlemen? I think this form part of what I said constantly, we should always be thinking about other things, strategies that will add strength to our own rights. There are rights here that I see them as outdated. So I think we too, as professionals, we should come together, think, bring up new issues that will sponsor that it will be part of an act that will favor us as well. Thank God people like them are within. We can package it with their own assistants, professional assistants. They will go through the National Assembly. We see that we'll pass laws that will affect the beauty of our own welfare and then protect us in our workplaces. Because the safety of our job is very, very important, not just the salary. Please, let's put our hands together for Barrister Helen. Thank you very much. Well, I said she's a lawyer. I'm also a lawyer. Well, she was called to bar. I was called to the bar. What's the difference? All of us are lawyers. Hello, all of us are lawyers. Who will tell me the difference? Seniority. I still know her by age. Certificate. Her certificate is with paper. My own is with paper. And they sign. My own they sign. So what's the difference? You said? Let me hear you. 10,000 for, if you answer well, 10,000. Give me your account number. What's our difference?
She has learned colleagues. You have skillful colleagues.
But skills and learned, which one is more important? If you are learned and you are not skillful, if you are skillful, you are not learned, which one is more greater among them? Now lie, if you don't learn, how you apply what you... So please, the difference is the THE. She was called to, I was called to the bar. That's the difference. See, that's why when lawyer want defeat you for court, but if you say that for court, like that, for don't defeat you. And I lie, they talk. The smart thing they say technicalities. Yeah, I attended technical school. Please, do we have some? Let's have some feedbacks. If you have some questions, if you have some doubts, or you need some professional advice, I think this is a time for us. Let's think. As a union, we need to review, let's add more strength to our own rights as professionals. If there's a question or contribution, please, this is a time for you. That's sure, okay. Whenever there is good, don't worry. She was asking me, is it good afternoon or good morning?
Good afternoon, professional colleagues, and good afternoon to our learned lawyer. We thank you for this beautiful presentation. Thank you, ma. Yes, she has said it all, She has taught us, and then my own is a little contribution. And now they are asking us, what is our own right in all this that protects us? We have said Child Act law, Criminal Code Act, all these things, she has said it. Then which one is protecting we nurses? And we couldn't think it out. But the right thing is doing the right thing. Anywhere I am, I normally say people, do the right thing and nothing else. So all those things that we have been taught, like my boy here said, our documentation, our this and our that. That is something if they say, oh, this patient, they said you didn't do this. You bring your documentation. I did it they said 12 p.m. and that's when I gave it. And look, I wrote it down. That one exonerates you. So it is doing the right thing, my dear. Attitude, our behavior. Let us do the right thing. Everybody knows the right thing. Spirituality is key. So let us do the right thing. Thank you.
Please, let's appreciate our ladies and gentlemen.
Good afternoon. Thank you very much, our legal practitioner. The right for we, the nurses, apart from doing the right thing, is for me to have the right to practice as a nurse by my own organization giving me the license, and also for me to practice in a safe and well-respected environment. If I'm not respected, as one of our colleagues said, that a nurse that hates, a patient that hates her, definitely she has the right to say, I cannot treat this patient because the patient can be violent and cause injury to her. So I have the right to advocate for myself and also for my patient. Thank you.
Apart from that, please, we need questions. For example, apart from that right, that you have the right not to treat the patient, and the patient who has the right to say, please, nurse, don't touch me. Abi? Fine. Then now, let's go in depth and think, is that the only right we have? Is that the only right we need? Now, for example, like this what we call malicious, let me call it, let me say, expression of malicious perception on the nurses. What had been the consequences of those who are trading such malicious perception on those are the acts we should begin to think. How do we go about it? Because you just give a blanket or stereotype perception about the nurses. Said nurses are very wicked, they are so beautiful, they are this. So those perceptions, let's think on a legal way on how to, at least she's still constantly with us, and see how we can put it. So those who do that should be prosecuted. Secondly, for example, if you treat me very well, as Oga rightly said, and I'm happy, I think do I have the right to come back to the hospital and then give tips to the nurses? If I'm happy and I have the money, I'm happy. I'm voluntarily I came on my volition. But some would see it as if it is a bribe. What right have you again to protect you in case I come voluntarily to give you? So think about this.
The moderator or the MC, the first question you were talking about, the issue of malicious intention, and of course, as even the other sister said there, as a person, I was asking for not as your rights as a citizen of Nigeria. I was asking if there's any act of, that protect the nurses as a nurse. But as a citizen of Nigeria, of course, you can sue someone for libel or defamation of character. If you feel the person is maliciously defaming you, you understand, all you need to do is to take the person to court and let the person prove it. And if you cannot prove it, of course, you smile away with heavy pockets because of the damages that you are going to claim. So that is it. But for the issue of gratification, I do, when I go to the hospital, it's like, this stereotyping you're talking about is not our fault. It's experiences people get when they get to the hospital. Most of us, my fellow nurses, we are not nice. You understand? And if I meet a nurse that is nice to me, it's like heaven has come down. I keep contact. I develop relationship. You understand? So when you go back and you do it, I don't think there's anything, except you have a law that is against that. But I don't think there's anything wrong in it, honestly. You go back to appreciate the person. The person didn't coerce you, didn't demand. You were just nice. That's why they say gratification is not bribe. That's my own humble opinion, anyway.
Thank you very much. Still on the gratification, when the 10 lepers were healed, at least the one that went and said thank you was the one that was appreciated. So please, going back to say thank you is good as well. So let's put our hands together for ourselves, ladies and gentlemen. All right, today is a very, very great day. I could see smiles on the faces of my wonderful nurses. On Tuesday, I said I regretted I would have been a nurse. And I said then, okay, fine, I am happily married. I would have married a nurse. Incidentally, my only son, second son, refused to marry, and he was ordained as a Catholic priest. So you see, so already I've missed nurse in my house. Okay, but the daughters again, unfortunately again, the 3 daughters, all of them read engineering. So where will I start from nursing again? So now I always go to the hospital and then be telling you, hello nurse, good morning. Instead of telling them good morning in my house, but that's no problem. Seeing your beautiful face will give me joy. Let me add this once again. Please, I beg you in the name of God. In industrial relations, what cripples the strength of a people or a union? One is lack of internal social justice, equity and fairness. Secondly, lack of commitment and entire solidarity. 3, if you see conflict as an enemy, you will never grow. Lastly, division will create this very serious hammer on you by your employers, because they are waiting like wolves to see that you are divided. That's why they say divided we what? We fall. United we what? So please constantly think about ideas that will add value to your executives. Don't hate anybody. Once election is held and your caucus did not win, throw the election away and then face the reality within the center. If not, if you take the outcome of the election, because mostly in the trade unions, that had been a crippling factor. It's a survey I've had. I'm the immediate past national PR of the radio, television, theater, and advocacy. I've been in research. I've presented papers within and outside. I'm telling you, that conflict is the most dangerous destroying factor. So don't agree. Nurses don't agree, and midwives don't agree. If you have a very conflict, I must not think like you. You must not think like me. See it that way. If you see it that way, it will pay you. I want to see in your beautiful colors. I cannot imagine a very beautiful woman, when you see her, because she's a nurse, then she'll begin to produce contour lines on her face as if she's a geography map, and which is not the best. I want to always see you happily, see your colleague, you shake her, you're happy. Just like they call mommy, they call her, as you see her go, she protested that she said, mommy, let me tell you, forget about that age. Forget about that age. You see, say all now, when daddy say one hard wife, and that time I could begin to read dictionary, say they read Bible. Because the reading no go to enter, because they think say that the fluctuation of the power. So at this very juncture, we will have a very, very product presentation. The company will take us around, the product will take us around to where we will definitely know certain things that we don't know. But all things being equal, I would have done the presentation by myself. I told you that day, I said my first university was ABU JAS. I proceeded to Bayero University, Enugu. From there, I went to Tafawa Balewa University, Owerri, where I read palm wine and matrimonial engineering. So thank you very much.
All right, thank you very much. We want to use this time to appreciate Barrister Helen, who have done justice to the paper given to her. And let me also use this time to also let us know she's a notary public. And for some of us who wants to japa, because we took a censor yesterday and majority actually wanted to japa. And you need to notarize your documents, particularly those of you going outside the country to go and for further studies. Knock at her door, she will do that for you. And for the fact that she's also attached to nurses, I'm sure she'll give you some at the discounted rate. Thank you very much. Please, this will be our last presentation for the day. So please, just bear with us.
Great nurses, good afternoon, ladies and gentlemen. My name is Pharmacist Jacob Ogbaji. I work with Zolon Healthcare, a subsidiary of the EMSO group, specifically focusing on the vaccines arm. So by profession, I'm a pharmacist. By association, I'm a nurse. My wife is a nurse. So last year I was in this same meeting. That's the one I held at the Women Development Center. And I spoke about hepatitis, viral hepatitis, and the nurse's role. So this afternoon, we will not be looking at what we did last time. It's the urgent call to action that we'll be looking at. We've had so much information, so what do we do with the information? That is the urgent call to action. And my presentation is in line with the World Hepatitis Day that occurs annually July 28 every year. And that will be the flow of my presentation. Now, this is going to be my outline. We'll look at, briefly, since we're not going to talk so much about the virus itself, we'll look at a brief overview, we'll look at the burden of viral hepatitis, the stages of liver damage, current realities in Nigeria, the key objectives of the 2023 World Hepatitis Day, WHO targets, and our role as nurses. Then what is our commitment as EMSO? And then we conclude. Hepatitis, as we know, as an overview, is an inflammation of the liver. And there are so many things that can cause inflammation of the liver. Drugs, toxins, alcohol, physical damage, viruses, other infections caused by bacteria and parasites. All these cause hepatitis, cause inflammation of the liver. But once it involves viruses, then we're talking about viral hepatitis. It's the inflammation of the liver as a result of a specific virus. And in inflammation, in hepatitis, viruses form the most important cause. About 70% of the inflammation of the liver is by viruses, and is responsible for 2 out of every 3 liver cancer deaths. 2 out of every 3. There are 5 main strains, which we talked about last time, A, B, C, D, and E. And these ones primarily infect the liver. Now, we have 1 life, according to WHO, and we have 1 liver. And yet, hepatitis threatens and devastates both. Because once a liver is damaged, it's like the life is damaged. The liver performs silently over 500 functions. Silently. So it is hidden, but yet it does a lot of functions. And yet, the hepatitis virus also comes in silently and does the damage silently. By the time you see a lot of the symptoms, the damage is far advanced. So when you protect the liver, you protect life. The theme for this program is our nurses, our future. And if we're going to have a future, particularly as it relates to the liver, we must protect it. We must protect it. We're interested in having nurses very paramount, very pronounced, very central in our future. Now, in the next slide, we'll look at the burden of viral hepatitis. This is very, very key. According to WHO, viral hepatitis is the 7th leading cause of mortality worldwide. And it is the only communicable disease where mortality is increasing. Others are decreasing, but for viral hepatitis, it is increasing. And then it causes at least about the same death, if not more deaths, than TB, AIDS, and malaria combined. It is that serious. And then worldwide, an estimated 354 million people are living with hepatitis B or C. And for most, testing and treatment remain beyond reach. For most of them. In fact, 90% of people that are infected with hepatitis don't know. So 9 out of 10 people infected with hepatitis don't know that they have the virus. In Africa, more than 90 million people are living with hepatitis, accounting for 26% of the global total. Nigeria has more than 20 million people living with hepatitis, That's around 10%, right? If our population is 200 million, 20 million, that's around 10%. And yet, more than 80% of people who have the disease do not know their status. And so, according to the Center for Disease Control, hepatitis B vaccines have been available in Nigeria since 2004. Yet, Nigeria has the largest number of children living with hepatitis B virus infection worldwide. Nigeria has the largest worldwide. It's a starking reality. Now, what are the stages of liver damage? It's important to understand this because I've received calls severally and they'll just call and say, this woman has been diagnosed with hepatitis. What drug do we get for her? Now, not everybody that is infected with hepatitis get the same drug. If you look at this, that's by the right is the healthy liver, by the left, by the extreme left, is the healthy liver. Now that's the progression of a disease. You get to fatty liver, where there are fat deposits in the liver that may lead to inflammation. Viruses can also be implicated here. And when I talk about fatty liver, I'm talking about non-alcoholic fatty liver because we have the one that is primarily caused by alcohol. Then it gets to hepatic fibrosis. Now, it is called the excessive scarring of the liver. Scarring is gotten from the word scar. When you have a wound, by the time the wound heals, it leaves a scar, right? Now, the same thing happens to the liver because of viruses, because of drugs, because of toxins, because of injury. That affects the liver. The liver tries to respond to defend itself. And one way of doing that is releasing fibrous connective tissues to help protect the liver. And now, by the time it continues to do that, you have excessive scars all over the liver. Now, this is bad, but it's not as bad as when it gets to cirrhosis. The liver can still perform some of its functions at the stage of fibrosis. And if what is causing the fibrosis is removed, the liver can recover fully. It may recover fully. However, if the source of damage is not removed, it can progress to liver cirrhosis. In liver cirrhosis, you have scarring, but in fibrosis, it is excessive. In cirrhosis, it is extensive. It covers virtually every part of the liver. The damage is irreversible. At that stage, the person may need a liver transplant because a lot of the drug you give at that stage may not do anything more to reverse it because it's irreversible. And then eventually it progresses from cirrhosis, it can progress to liver disease or liver cancer, can lead to death and all that. And this is a forum that I am passionate about because I don't think among the health workers there are people that relate with patients as much as nurses do. And because of that, it's important that nurses are protected. The hepatitis B virus is about 50 to 100 times more infectious than the HIV. HIV, within minutes, the virus dies. But a hepatitis B virus can stay on the surface for about 7 days and still remain infectious. So it is that infectious, it's that dangerous. So that's the importance, the need why we must protect ourselves. What are the current realities in Nigeria? Number one, most patients have the wrong impression of the disease. And what they know is often only the negative. When you say come for screening, you say, God forbid, I know I don't have it, so no need for screening. The things they know about it are usually negative. And then many patients discover their diagnosis accidentally. They didn't go for the screening, they went for something else and decided to let's do HBV screening, while they are donating blood and all that. They discover it accidentally. And then there's a lot of stigma surrounding hepatitis, which often prevents people from seeking timely testing. If people know that I have hepatitis now, it becomes an issue. And so it perpetuates the circle of infection. High cost of treatment, yes. For those that are positive, you know the price of the drug, because the drugs are not something, for hepatitis B, for instance, there is no cure. It is treatable, but it's not curable. And so you may need to take that drug for life. It's a chronic infection, it's a chronic condition, just like hypertension and diabetes. For people taking antihypertensive or antidiabetic drugs, it doesn't get to a point where they say, okay, you are free. You won't take the drug again. Highest, as you get better, they reduce the number of drugs you use, or they reduce the dose. The same thing with the hepatitis. It's a lifelong treatment, and it can be very expensive. Except for hepatitis C, that is curable, it's treatable. Within 12 weeks, you can cure hepatitis C. So high cost of treatment. And then late case presentation, by the time they come, the damage is done. Something happened at the teaching hospital in Gwagwalada. One of the nurses close to my wife, who didn't even know. By the time they admitted him, the liver damage was far gone. You see ascites, accumulation of fluid because of cirrhosis. And by then, before we know it, in a few days' time, he was gone. This is something that is preventable. And it pains me when health workers, particularly nurses, are down with hepatitis B or hepatitis C, that is usually preventable. Late case presentation, hepatitis is underreported, underdiagnosed, and undertreated. And then finally, failure to complete the 3-dose vaccination. I'm sure there are 1 or 2 people in this room that will fall victim to this. They will take first dose, will forget about the second and third dose. Or they will take first and second, and they will leave the third dose. These are the current realities in our country. Now, for the World Hepatitis Day 2023 objectives, there are 4 objectives. Number 1, promote prevention, very key. And one way to promote prevention is vaccination. Number 2, increase testing and early diagnosis. From what I've explained, from the stages of liver disease, early diagnosis is key, right? Early diagnosis is key. If you catch it on time, you can prevent some of the other complications. Access to treatment and care. Yes, somebody has been diagnosed and is positive. Access to treatment and care is key. Combat stigma and discrimination. These are the 4 points objectives for World Hepatitis Day. Now, for WHO, the target is this, that by 2030, reducing of new infections of hepatitis B and C by 90%. New infections, reduce it, and that's where vaccination comes in. Number 2, reduce hepatitis-related death from liver, cirrhosis, and cancer by 65%. Reduce the death by 65%. Ensure that at least 90% of people with hepatitis B and C virus are diagnosed. The screening comes in. At least 80% of those eligible receive appropriate treatment. So if somebody comes to you and says, I've been diagnosed with hepatitis B, and can you recommend drug? It is essential to refer him to appropriate care. Because if this person is taking this antiviral medication, it may not work for him because it will depend on the stage. It is the stage of liver damage that determines the drugs that are used, the number of drugs that are used, and the type of antiviral medication to be used. So it is key that we refer them, link them to care. Very, very important. Now, I've said this time and time again. Screening is important. Whatever the outcome of the screening, you must take action. I've seen situations where people do screening for hepatitis B and they check and they're negative and they say, thank God, and they walk away. Whether the result is negative or positive, it is a call to action. If it is negative, the action is take vaccines. Because it is when you take those vaccines, the complete dose, that even when you expose yourself, you are already protected. Your system is already primed to withstand the virus. That's if the person is negative. If the person is positive, there's also an action to take. The action is to seek help fast so that you can arrest any further complications. So as the role of nurses, as nurses, our involvement is essential at every stage of the elimination circle, from prevention and screening to treatment to support for affected individuals. Nurses play roles in each of these points. Public policy advocacy is key. We cannot advocate enough about the importance of viral hepatitis prevention and control measures. Screening, preach diagnosis and treatment. Timely diagnosis. That the operative word is timely diagnosis for patients to prevent complications and, of course, transmission. Education. Nurses occupy a very central role. They are among the most influential sources of information about immunization behavior. So it's important to educate patients. Because a lot of them have negative connotation, they have negative understanding. So it is your role to give them the right picture. And then, immunization screen and history. Try to find, have you taken hepatitis B vaccine? Have you been screened? how many doses did you take and all that. Implementing prevention and treatment programs that have been set up. Of course, monitoring and surveillance. Part of the objective is to reduce new infection. If you want to know, this is where I am, this is where I want to get to, how do you know that? You need to monitor and survey. Action points for nurses, increase awareness, whether one-on-one or use your social media handles, your platforms, the nurses' platforms, podcasts, every other opportunity available to provide current, reliable, and relevant information. Leverage on partnership. Several stakeholders want to partner in delivering effective vaccination services, consistent and continuous vaccine advocacy programs at all levels. Send out proposal for vaccination. Corporate vaccination, you are in the corporate environment, and you want us to come in, we can come in. Open field outreaches in schools, outreaches in school of nursing, colleges of nursing, and all that. NGOs, family and friends, continually advocate for those. And then, very importantly, practice what you preach. Endeavor to get vaccinated yourself. Healthcare professionals are exposed to all kinds of potential dangers, potential infections. So for us, what is our commitment? Training and retraining on vaccination services. Send out proposals for training, we'll get involved. Support materials for screening and vaccination, especially against hepatitis. We provide some of these screening materials for free, and we also partner to ensure people are screened and vaccinated. Reliable and relevant information we can provide. We'll make available promotional materials, flyers, banners, partnering and sending out a proposal, of course, sponsorships with support of relevant vaccination-related events. So for us, the goal is for us to be the house of vaccines, a one-stop shop for vaccines generally. And why should you consider Emzor vaccines? Number one, quality of our product. I'm sure everybody here knows Emzor. We'll talk about Emzor paracetamol. It's a household name. You know the quality of our product. The same quality extends to our vaccines. If they are effective, they do their work. They contain vaccine vial monitor. It's a monitor that tells you the viability of your vaccine because it's sensitive to temperature. And temperature, the vaccine is supposed to be kept between 2 and 8 degrees centigrade. That VVM will tell you if it's outside that range. So what you have, those 4 boxes in a circle, the first 2 tells you the vaccine is viable to be used, while the last 2 down tells you do not use, even if the expiry date is still far away. The vaccines are safe, they are affordable, we have guaranteed cold chain, and of course, trusted source. So as we conclude, millions of people are living with undiagnosed and untreated hepatitis worldwide, even though we have better tools today than we used to have to prevent, diagnose, and treat it. And then this year's World Hepatitis Day team, we are not waiting, emphasizes the urgent need to scale up testing and treatment of viral hepatitis to prevent liver disease and achieve the 2030 elimination goals. Last year, the focus was on prevention, but now both prevention and treatment. Because if you are preventing those that are already positive, what do you do for them? How do you support them? And then finally, together, we can raise awareness, we can enhance prevention efforts, we can improve access to care, we can ultimately reduce the burden of viral hepatitis. Thank you very much for your time.
Please, let's put our hands together for him, ladies and gentlemen. This is a very wonderful presentation as well because it has added another feather to the strength of our knowledge. Please, let's put our hands together, ladies and gentlemen. We should take this very week very serious because a lot of things must have added onto us. And I ask God to grant us His grace to do that which we have chosen to do. And may God reward us in our various commitments. Abi? Do you know that this prayer in Wari, if you say now for Wari, I say this prayer now 50K. But me wanna bring 115. My manage. All right, thank you very much, ladies and gentlemen, for being with us. We appreciate your presence, and we ask God to crown us. Okay, let me receive an instruction not to be like yesterday. All right, we are kickstarting the tea break right away. Sorry. What we will do, we don't want the place to be so crowded. We'll be moving table by table, table by table. By the grace of God, it will reach all of us. Because at least we have the number, we have our number here. So please, just remain where you are. They will give us food. And I think the MC will have his refreshment at Nikon. So I'll be going before I come back in the evening. Thank you very much.
For tea break, while the tea break is on, perhaps if anybody has questions as regards to the presentation made from Enzo, I think we can welcome that while the tea break is on. Then for those of us, I said something earlier, to those who came late, if you know you have not done that barcode to do the registration and the pre-test and post-test, please make sure you do it before leaving this hall. Then I'll put another barcode on the screen for evaluation of what we have done so far. So we'll do that shortly. Any question, please? All right, please come. Please come. Come. The tea break is on. For those of us at the back, let's start going for tea break.
Thank you. Fam, we really appreciate your presentation. My own question is, what's the place of Livolin in liver treatment? And another thing, are you saying fatty liver, is it the hepatitis that causes it, or what's the correlation? That's what I want to know.
Thank you for your presentation. Please, I would like to ask you that, when some people mistakenly take hepatitis vaccines without being screened, and afterwards, after screening, you discover that that patient is positive, what is the effect? Then the second question I want to ask you is, some school of thought says when you take hepatitis vaccine after testing, you will say, okay, you are protected for life. Some will say for 20 years. Please, how sure are you? How best can we say you are well protected for a lifetime? Thank you.
Thank you for the presentation. Please, I would like to know if at some points by taking the medication over a period of years, is there any possibility of the virus not being seen anymore after after a checkup again, maybe the virus is totally gone, or even if or maybe it will come back again? I just want to understand that.
Thank you for your lecture, sir. I just want to find out, is there any way, since you are producing these vaccines, that we can have a shot, at least just one shot to cover the 3 phases or stages that we are supposed to? A shot, can you produce that? Can your company do that for us? Thank you.
All right, thank you, sir, for the presentation. My question is about the treatment. We've seen cases where patients are treated for Hep B, to be specific, and it's no longer detectable after the treatment, and after a while, it surfaces again. And we don't know whether it's a reinfection, but we've also seen some literatures that have attested to the fact that after treatment, patients that are treated are still convalescent carriers and can still infect other persons. So I just wanted to throw more light on that. Yeah.
Thank you. All right. Okay, thank you very much. The first question is the role of levolin-4. Now, levolin-4 is one of the drugs that is used to protect the liver. But personally, my recommendation is levolin-4 should be a drug that should be prescribed. Do you understand that? Should be prescribed. You don't just go get it for yourself. Because there are level of liver damage that Livolin Forte will not be able to do anything. So for it to be prescribed, you need to be tested, check the function of the liver, check the stage of damage of the liver, then you would know whether Livolin Forte is indicated or not. Because once the liver is advancedly damaged, no matter how many Livolin Forte you take, it will not do the work you need because the damage is now irreversible. So it's at the early stage of liver damage that Livolin Forte plays a role. But once it is advanced, and then there is no way to tell whether it's advanced until you go for checkup. Is that okay? Yes. I just remembered something. I think I should mention it before I proceed. One of the things that cause inflammation of the liver are drugs that damage the liver. And one major drug that is implicated is paracetamol. People take paracetamol like the way they take iron. That's why when you're being prescribed paracetamol, usually it's for how many days? 3 days. 3 days. Paracetamol contains what we call acetaminophen, and it is hepatotoxic. It means it has effect on the liver when you use for such a long time. So once that pain is persisting beyond those 3 days, it means you should seek help. I'm happy that we spoke about headache today. So if you are treating the symptom without taking care of the underlying cause, it will still come back. So as much as possible, please. In fact, if you know a person that is down with hepatitis already, those drugs are no-go area. They can give them another alternative medication for pain. But paracetamol is one of the drugs implicated in liver issues. But if you take within the normal dosing, it's fine. Some people like this, my headache is too strong. I will take 4 tablets at once. Those are the things. There's so much the liver can handle. So I think it's important to mention that. Yes, somebody asks if viral hepatitis is implicated in fatty liver. Now, there is what we call alcoholic fatty liver and non-alcoholic fatty liver. For non-alcoholic fatty liver, viral hepatitis is sometimes indicated. So what that means is that there are some other things that can cause viral fatty liver. And the viral hepatitis sometimes is implicated in it. It's not as if it's viral hepatitis that is the sole cause of fatty liver. Other things can cause fatty liver aside viral hepatitis. And like I mentioned, that somebody, maybe this will address some questions. Somebody has taken the 3 doses of hepatitis vaccine and still comes down with hepatitis. Is it possible? Yes, and I've explained why. Viruses are not the only cause of hepatitis. So the person's hepatitis may not be a viral hepatitis. It may be caused by other drugs. Number 2, some people, one of the questions asked, somebody did not screen and went to take hepatitis B vaccine. It's possible that the person is already infected. Now, it is not as if when you give the person the vaccine, it worsens the situation. Why there's a need for screening is because if a person is positive, that vaccine you are giving is useless. The vaccine is supposed to prevent, but somebody has something you want to prevent. Why are you giving him the preventive medicine? So there is no need for a vaccine for somebody that is already positive. That is the essence of screening before vaccination. It's not as if you vaccinate before screening, it causes any extra harm to the liver. Okay? Now, taking the 3 vaccines, the 3 doses, are you protected for life? Now, ideally, to a large extent, you are. This is the question mark on it. People respond differently. Their systems are different. And so, once in a while, they say after 20 years, you can go for what do you call it, to check the level of the vaccine efficacy in the system. If it has gone down, you may need to take a booster dose, just 1 dose to boost the immunity. So people's immunity differ. But ideally, once you take the 3 doses, it should supposed to cover you for life. While we're still on this subject matter, I also need to address something about dosing. Before now, it's been said that if you take the first dose and you not complete the remaining second or third dose, or you take the first and second, you not complete the third dose, you need to start all over. How many of us have heard that? Yes. But recently, WHO has come up with a statement that when you take first dose, it's only first dose you took, and you forgot to take the second and third doses. When you remember, continue from where you stop. So you just need to take second and third. Or if you take first and second, you forgot to take the third one. By the time you remember, you just go take the third one. Now, to address another question, I have taken the 3 doses of, it's possible that I have taken the 3 doses of the vaccine, but I cannot remember. I know I took many vaccines some years back, but I don't know whether it is hepatitis B vaccine or not. So what is my style? My recommendation is go for screening, and if you are negative, take the vaccine. If you take another shot of the vaccine, it's not a danger at all. It is not a danger to you at all. So somebody asks, instead of giving 3 doses, why don't you manufacture 1? So that by the time you give the 1, it covers all. Now, if you understand the way the hepatitis B virus is, it's a very, I didn't show you the structure of the virus. The part of the virus makes it very difficult. That's why it's up to now there is no cure for it. And so a single dose will not be able to muster the system's ability to protect you. When you take only 1 dose, the protection is around between 50 and 60%. It's not so much. You need to take the second dose to get to 70, take the third one to take you far into the late 90% to protect you. And so, for now, maybe it's something that can happen in the future, but for now, we are stuck with 3 doses of the vaccine. Okay? Now, those that are positive, they are on medication, and then later. Now, it's important to understand that once you are positive, you are positive. Because if you have a medication that can clear the viruses from the system, that is cure. That is cure. But these drugs do not remove the viruses from the system. What they do majorly, particularly the antiviral medication, is stop the viruses from replicating. Because if you understand the way it works, when the virus enters the system, it's not then it starts damage. It doesn't start damage. It needs to multiply, replicate, to have a good number before it begins to do the damage. So what the drug does is to prevent replication. But the virus is still in the system. So if you stop taking the medication, replication resumes. And so that's why somebody can still, even though he's on took medications, but stop, can still come down with it. It's important to understand this. So when you are on medication, the doctor must give you a follow-up date. Because even if you take it for 3 months, you need to come back. Let's check the level of the virus. What's the viral load like? And then it will determine, the level of drugs, the number of drugs, and all that. But like I mentioned, for chronic conditions, it doesn't get to a point where you're like, I am drug-free for hepatitis. So that's why a person that is on medication, if he stops medication, if he goes for tests, you still see some of those signs that this one is a carrier of the virus. I think I've addressed all the questions, right? All right, thank you very much for your time. Meanwhile, we have a stand behind. I mentioned Zolon. We do Recmal, we do azithromycin. Recmal is our test note injection. We have Zegem syrup, our iron-containing syrup, and some other medications behind. As you go behind, you can take a look. Thank you very much.
Let's take our tea break. And as we are doing that, for those of us who are yet to do, let's do the evaluation of the entire program. It's important. You already have the QR code. This one is different from the one we had in the morning. This one is for evaluation, so everyone too is expected to do this. If you do this one, that's what confirms that you waited till the end. The first one we did in the morning is what will confirm your registration and your eligibility for certificate collection for the program. Okay, I can see some people have started submitting. About 6 people have responded. That's fine. Okay, the number is increasing. Thank you very much. Then in the morning, what I have so far for morning, okay, I've gotten at least a little bit above 150 for morning on. That's fine.